Well, hello everyone. Welcome to ASCO's Online Clinical Educators Forum. My name is LaShawn Sidbury, and I'm the Director of Special Interest Groups and Meetings at ASCO. Now, before we get started, I'd like to go over a few housekeeping items regarding today's event. We've taken a screenshot as an example of the attendee interface. You should see something on your screen that looks like this. So if you look at the upper right-hand corner, there's an orange button that allows you to minimize and expand the view of your control panel. When you join today's webinar, you selected to join either by phone call or by computer audio and listen-only mode. If for some reason you would like to change your selection, you can do so by accessing your audio pane and your control panel. Those participating in Canada may need to click on other numbers to find a dial-in number for your country. If you have any questions during the presentation, please type them into the questions pane of the control panel. Session moderators will bring up questions during the Q&A section, which is at the end of each session. Please also use the question box to let us know if you're experiencing any technical difficulties. We have Sarah Lau, ASCO's Business Operations Manager, and Alex Job, GoToWebinar's Technical Specialist, joining me to provide the best possible technical assistance during the event. I would now like to hand the session over to Dr. David Damari, Dean of Michigan College of Optometry, President-elect of ASCO, and Chair of ASCO's Clinical Affairs Committee.
Thank you, LaShawn. It's my pleasure to welcome everyone today, whether it's afternoon or if you're in the mountains or on the West Coast, good morning. As LaShawn said, I'm Dr. Dave Damari. I'm chair of ASCO's Clinical Affairs Committee. Actually, this is probably my last action as chair before the annual meeting. And I'd like to acknowledge the entire committee and planning group. And we'll acknowledge them again at the end of the program. But before we start, special thanks to our planning group co-chairs and moderators, Dr. Stephanie Klemenczyk, Dr. Kayla Asmotherly, and Dr. Neil Pence. And also thank you to the rest of our working group members, Dr. Maria Parisi, Dr. Beth Steele, Dr. Angel Noble Simmons. And finally, thanks to two people who are absolutely critical in having brought you this forum today, and that's Carol Brubaker and LaShawn Sidbury on the ASCO staff. They keep us all on track, believe me, and without them we would not have been able to do this today. So Carol and LaShawn, many thanks to both of you. This is really important. If you are in a group viewing session and you're all logged in as one user, please start an attendance sheet and write everybody's name down that's attending. We really need to keep track of how many people are logged in today for this forum and who they are, because that's very helpful when we look for financial support for future programs. At the end of this program, the institutional liaisons should then collect that attendance sheet or those attendance sheets and email them to Carol Brubaker, and her email address is cbrubaker@opted.org, or you can just go to the ASCO website, click on the staff link, and her email address link is there. Also, at the end of the event, and by the way, this is not the last time you will hear this, please go to our SurveyMonkey evaluation link and take our survey so we can assess what we've done today and use the information for future planning. We have 3 sessions planned for you today. Each one will move pretty quickly. Each section has a moderator. So please feel free to use that question box on your GoToWebinar control panel. And with no further ado, I'd like to introduce the moderator for the first session, Clinical Updates, which is Dr. Stephanie Klemenczyk from ICO. Stephanie, take it away.
Thanks, Dr. Damari. It's challenging enough to stay up to date with the latest and greatest within your own area of interest, much less within all areas of eye care. Therefore, we put together 4 short clinical updates on a variety of topics. So for this session, we will be hearing from Dr. Nate Lighthizer from Northeastern State University, Oklahoma College of Optometry. Dr. Lighthizer will be presenting a laser procedures update as it relates to the NBEO examination. After that, we will hear from Dr. Jennifer Harthen from the Illinois College of Optometry. Dr. Harthen will be updating us on contact lenses. Then we have Dr. Yin T from Nova Southeastern College of Optometry. Dr. T will provide us with updates in pediatrics and binocular vision. And then concluding this session will be Dr. Danica Morelli from the University of Houston College of Optometry. And Dr. Morelli will be updating us on glaucoma. Please note we have reserved some time at the end of the clinic update session, so this is after all of our speakers have presented for any questions, but definitely feel free to type them in using the question box on the webinar control panel at any time ahead of time. And then after all of the speakers have presented, I'll direct the questions to the appropriate person. So let's kick off this session by hearing a laser procedure update, and I will now turn it over to Dr. Lighthizer.
Still. Thank you, Stephanie. I appreciate the opportunity to present at the Online Clinical Educators Forum on a laser procedures update. Again, my name is Nate Lighthizer at the Oklahoma College of Optometry, and again, my pleasure to be here. This is a topic that certainly is a passion of mine, is an interest of mine, and it seems to be expanding over the course of the past 3 to 5 years, and we'll talk more about that as we go forward here. I'm fortunate to head our specialty care clinic where we do all of our laser and surgical procedures, again, at the Oklahoma College of Optometry in Tahlequah. So before we get to the NBEO stuff, just one slide, kind of, what's the status of lasers and really surgery and optometry as well. They are 2 different avenues or arenas, yet they're linked together, but there's a few differences between them as well. So but let's start with specifically lasers and who's passed legislation. As many of you know, Oklahoma has kind of been it's been standing out for a long, long time as the only one. I remember going to school at Pacific University, and where I graduated there, 7, 8, 9 years ago, and thinking that was the only state, and it was the only state. But since then, there has been a couple of others. Kentucky in 2011 passed their law that matched Oklahoma's, and Louisiana in 2014 as well. And when I talk on lasers and advanced scope of practice, I always say, again, for a long time it was just, and I say this with kind of a joke, it was just crazy Oklahoma for a long time. And then state number 2 got it in Kentucky, and then state number 3 in Louisiana. And I really believe that that was getting close to the threshold, going, okay, that caught people's attention. Once you have 2 states, it's easier for the 3rd, and once you have 3 states, it's easier for 4, 5, and 6, and so on down the line. A lot like drops and orals over the course of the few years. So, I think those are the 3 that they've passed the legislation. It's been done. There were 3 other states that had legislation this year that are currently in various stages of trying to get passed or going through that process. And then this last bullet, the states that are planning their advanced scope legislation. I'm not going to list them because they've asked us, not to spread the word, but there are over a dozen, close to 15 or 20 that are in the planning stages that, in the next 2 to 5 years, they're looking at scope expansion and saying, okay, we've had orals for a number of years, and now we're looking at the injection side. We're looking at the laser side as well. So it seems to be one of the interests in optometry moving forward is what's the next step? And optometry has become much more of a medical profession over the last 15 or 30 years, whatever it is, and this tends to be the next step in that. So that's kind of the status of lasers in optometry. We feel fortunate that a lot of states have acquired the interest and really are looking at the next step here. So that's kind of the status of lasers in optometry, and that brings us to the NBEO. And I think all of us are probably familiar or aware that the NBEO has started to adopt a laser and surgical testing, a test basically, of a practical as well as a written. They are working on that. Currently it is going to be optional. I believe they're going to roll out the first of these optional tests either in the second half of 2017 or maybe the first half of 2018. That hasn't been totally decided yet. I am not on this committee. I'm not involved with any NBEO committees, but they asked me to go and be a beta tester, basically, back in August of 2016 to sit through this laser and surgery practical. So what does it entail? Well, there were 3 laser stations on this NBEO laser practical. Again, they brought in various doctors to make sure this was real life and make sure everything made sense. And there was a capsulotomy station, a laser PI station, and an SLT station. You know, and this is the point where I think it's appropriate. You know, why are they looking at this, or what are the skills entail? Certainly it's a new skill, but you know, I believe, and this is just my personal belief, that you all would find that these lasers are very similar to a slit lamp skill that all of us entail already. And it's just learning a slightly new technique as you're doing it, and this is what they're being tested on now. So capsulotomy, laser PI, and the SLT station are the 3 laser stations that they are looking at. What's the equipment? Well, the laser being used is the Luminous Select Duet. I've got a picture of that right here. This is a combination laser, meaning it's both, it has a YAG component and an SLT component. So it will do capsulotomies, it will do iridotomies, it will do SLT. Depending on which mode you put it on, it will do that laser. So it's the same laser being used for all 3 laser testing stations that they're doing: YAG, capsulotomy, laser PI, and SLT. Let me show you. This is the Latina Lens. It's an SLT laser lens. That's what's being used. You have to use that to do the SLT station and the actual SLT procedure that we do on patients there. But just so you're familiar, when they have this laser testing station for the various procedures, that's the laser, the Luminous Select Duet, and the lens required is that Latina lens. For the capsulotomy station, you don't have to use a laser lens. For the iridotomy station, you don't have to either. They do have Abraham iridotomy or capsulotomy lenses, but we didn't use those as I went through this station. So that's the laser being used. How about the Model Eyes? And the Model Eyes were made by an ophthalmologist, Dr. Stuart Stoll, who practices in California. And we've got to know Dr. Stoll over the past few years. His business, or his company, is called Simuleye. He makes simulation model eyes for various ophthalmic procedures, both optometrically speaking and ophthalmology speaking as well. He makes a model eye for capsulotomy, for LPI, for SLT, for PRP, cataract surgery. He can make all these model eyes. Again, that's kind of his thing. That's kind of his business, making these model eyes. So what has the NBEO adopted or used? Obviously the capsulotomy, LPI, and SLT model eye. This is the capsulotomy model eye. And actually, you can see there's an actual real IOL inside this model eye with a membrane that simulates how a posterior capsular membrane would break up during a YAG laser capsulotomy. So again, it's a very, very nice model eye to simulate what that procedure would be like. There's an LPI model eye. I'll talk about that in just a little bit. Here's the SLT model eye. I use this SLT model eye. There's actually a newer version of this. This model eye on the right is fantastic. It's the most real-life approximation to an SLT that you can get without doing an actual procedure. So that model eye with the green iris on the right is very, very nice, and he has since upgraded that, and the model eye went from really, really good to even better. So it's very, very real life. Makes them put that Latina lens that we just talked about right on the eye, and basically demonstrate the procedure. So that's the capsulotomy model eye on the left and the SLT model eye on the right. We encouraged, there was multiple of us, encouraged Dr. Stoll to come up with an LPI, a laser peripheral iridotomy model eye, and he has since done that. I don't have a picture of that here, but there is an LPI model eye as well, where you poke a hole in the iris and do that procedure there. So those are the model eyes that are being used. You can see a suction cup on the back of them. They suction to this right here. That's basically the holder. And you can see what that looks like. It just attaches right to the slit lamp, and those model eyes suction right to the back of that. So this is what our students purchase as they take our laser course, and that's what they use. The model eyes run $50 a model eye. I'm not affiliated with Dr. Stoll or anything like that, but just for FYI, I figured that might be a question, and that stand runs $100 to purchase that. So those are the model eyes that are being used for the NBEO laser practical on that one there. So, how is this test being validated? We've got, this test is in, obviously in Charlotte, North Carolina. How are we making sure that this is done the correct way? Like I said before, outside doctors have been brought in from various states, Oklahoma, Kentucky, and Louisiana, doctors that have an experience doing these procedures. And I was part of the first group in August of 2016. It was myself, Dr. Nimesh Patel from the Houston College, Dr. Mike Sullivan, me, who practiced for a long time in Oklahoma, and Dr. Jason Rines, who has a private practice in southern Oklahoma. We were the first group. There have since been 2 other groups of 4 doctors that have went, and basically they were the student. We were the students sitting through the YAG, the LPI, the SLT, and the surgery station, which we'll talk about on the next slide, and basically validating, yep, this works pretty good, this is pretty real life, I wouldn't do it this way, or I would change that. So there's been 3 groups of 4 doctors that have went through and tested this. They're looking at a few more beta testing sessions before they go live with this. Again, it's probably going to be optional. It will be an optional test, a standalone optional test for the foreseeable future. That's available for certain students that would like to take that NBEO laser practical. My last slide is then looking at the other side of this is the surgical side of that, of the NBEO surgical testing. There were 2 stations, a Chalazion station as well as a suture station, and you can see the Model I. The suture station supplies are on the bottom left there, and it's actually a very, very nice model that they have, and we now use at our college. And you can see it's just a portion of the face that includes the eyelids. If you open that eyelid, there's an eyeball underneath there, and a little incision is made into the skin, and then you can suture that back up. So that's kind of the suture station. The Chalazion station has a little pad there with some cheesy-like material in that, and again, you walk through the steps of doing that Chalazion removal with those various instruments there as well. So that is a quick update on the laser and surgical stations and the status of lasers and surgery in optometry right there. So with that, I will now hand it over to Dr. Harthen.
Thank you, Dr. Lighthizer. Good afternoon. My name is Jennifer Harthen, and I am Associate Professor at the Illinois College of Optometry and Chief of the Cornea Center for Clinical Excellence at the Illinois Eye Institute. Today, I am going to provide you with a very brief contact lens update and what we've learned this past year. This has kind of been the year for astigmatic and presbyopic correction. We have also seen a lot in regards to digital device use and contact lenses. I'm going to highlight some of the new information regarding mainstream lenses and solutions rather than on specialty lenses, and hopefully you'll be able to apply some of the information provided when working with your patients and students. I would like to thank the various contact lens companies for providing some of the information that will be presented in this update, as well as the ASCO Clinical Affairs Committee for the invitation to speak today. Sorry for the delay there. There are so many great lenses available, and a question that I often receive from some of my colleagues as well as patients are, what contact lenses would you recommend for someone who has dry eye? Well, the Dailies Total 1 lenses are a great option for patients with dry eye as they feature the water gradient technology. What exactly is the water gradient technology? Well, it's a silicone hydrogel material with very low water content. But then as we approach the surface of the lens, we have almost 100% water at the outer surface and essentially no silicone. So this makes the lens very breathable and very comfortable. This technology makes the lens ultra soft. As the lens is ultra soft, it provides great comfort, but you also want to remind your patients that these lenses may handle slightly differently. They can be quite slippery as the patients are learning to put them on and take them off. This year, Alcon released a multifocal option in the Dailies Total 1. It's a near center available in low, medium, and high add powers. The great thing about the multifocal design is that it allows for smooth transition from the near center vision to intermediate and distance viewing. So patients are now able to have stable vision and improved comfort for longer periods of time. We're all familiar with the Dailies Aqua Comfort Plus family of lenses. They're available in sphere, toric, and multifocal options. These lenses also provide patients with great comfort. As the patient blinks, a moisturizer and comfort enhancer are released from the lens, and this maintains a stable tear film throughout the day. A couple of things to keep in mind when fitting this particular brand of lenses. If you're fitting the multifocal lens and you don't have the multifocal diagnostic lens available in your fitting set, you can substitute the Air Optics multifocal as it's the same design. A nice feature with the Dailies Aqua Comfort Plus Sphere lens is that it's the only one-day lens available in this high of a plus and minus lens. So it's a fantastic option for patients with higher prescriptions who need a more frequent replacement schedule. It's available in the +5 and now all the way up to a -15. The Air Optics family of lenses, Alcon silicone hydrogel monthly lenses, have been around for several years, but this year we saw Alcon introduce the Air Optics with Hydroglide. It combines their Smart Shield technology with Hydroglide Moisture Matrix, and the whole goal of this is to allow for deposit resistance and longer lasting lens surface moisture. So this is great for patients who tend to have increased lipid deposits on their lenses. I also find that it works well for patients who tend to wear a lot of makeup and you see more debris in their tear film. We don't tend to see as much debris accumulation on their lenses with the Hydroglide. If you haven't checked out airopticschoice.com, it's a great website that provides savings for this family of lenses. Another website to check out is myalcon.com. It has great education resources available for practitioners and patients regarding lenses, solutions, insertion and removal training videos, fitting guides, clinical contact lens management. It also has access to the Colors Education Salon and contact lens grading skills. Alcon also added the Hydroglide Moisture Matrix to ClearCare, so this formulation is now called ClearCare Plus. We still have the same cleaning and disinfection as the original ClearCare solution. The Hydroglide technology was just added to provide longer lasting moisture to soft lenses when using this solution. B&L now has a complete one-day family in the BioTrue Sphere, astigmatic, and multifocal lens designs. The BioTrue One Day for Presbyopia lens was the most recent lens introduced, and it has a 3-zone progressive design. This means that the near add power is across the entire center portion of the lens, and it then has an intermediate consistent zone where the add power gradually transitions to the distance. I have found patients have less distortion at distance with this lens design compared to some of the others, and this is especially important for those who tend to do a lot of driving. With B&L, as with their spherical lenses, spherical aberration control is very important in the development of both their BioTrue one-day lenses as well as their Ultra lenses. The Ultra lenses are B&L's newest monthly replacement lenses, and I have found these to work very well clinically. Patients have been very happy with both the vision and comfort, and the Toric lens is one of my new workhorse lenses. It's been very stable and comfortable, and the lens material is designed to meet the demands of digital device users. Some patients will complain of decreased vision in dim settings. They have problem reading menus, and this may be due to spherical aberrations. So the Ultra lenses help to reduce inherent and induced spherical aberrations, making vision sharper. I most recently fit a patient with this lens this past week who takes long road trips in her RV with her husband. She actually drove her RV into the parking lot and asked, "What can you do to help me see long distances?" She has 2 diopters of astigmatism in one eye and is an early presbyope. She would often complain that her distance vision when driving was not sharp enough, especially at night. So we fit her with the Ultra for astigmatism on one eye and the Ultra for presbyopia on the other, and she sent me an email saying that her vision hasn't been this clear in years. So another lens to keep in mind when you have those patients who are struggling and need more high definition vision. MyDay and Clarity are Cooper Vision's one-day lenses. MyDay is Cooper's premium one-day lens. Contains smart silicone, so that's a lens at just 4.4% silicone. So when you have low amounts of silicone, that's a lower modulus. So you have then increased comfort and moisture. So this is a very soft and easy to handle lens. So if a patient is having a hard time with handling, you might want to think of the MyDay lens. The Clarity One Day is the first complete family of silicone hydrogel one-day lenses, and they're very affordably priced. They are priced at the level of conventional hydrogel lenses. In the Clarity multifocal, the sphere power for the multifocal is available in a +5 to a -6. A program that I think is fantastic with CooperVision that you may be aware of and some of you may not be is the Adoptive Patient Program. This program provides 3rd and 4th year optometry students the opportunity for additional hands-on fitting experiences. The program also benefits prospective contact lens patients who are otherwise unable to afford contact lenses. So 3rd year students in participating schools are encouraged to adopt a deserving patient into the program. Patients are fit with CooperVision lenses and are supplied with an annual supply of lenses. VSP provides vouchers for the fitting fees, and the students are then able to follow these patients along the course of their clinical experience. If your school isn't signed up for this program, I would encourage you to do so. It can be quite rewarding. The Biofinity family of lenses are Cooper silicone hydrogel monthly lenses. The XR lenses have extended parameters in the Biofinity material, which is great for high hyperopes and myopes. The benefit of these lenses is that we now have higher powers and a more frequent replacement schedule. It's a healthier option for some of these patients. And all the Biofinity lenses have aquaform technology. So this attracts and binds water throughout the lens to retain moisture and minimize deposits. Cooper's newest lens is the Energis, and this was developed because of increased accommodative burden and reduced blinking due to increased use of digital devices. We're hearing more and more about how many patients, practitioners, students are using digital devices. With increased digital devices, we have worsened comfort. So this lens features digital zone optics to help with eye fatigue. It has multiple front aspheric curves across the entire optic zone. This allows for patients to focus back and forth between distances more easily. It fits like a single vision lens, and I have found this lens to work great on students. The Avera Vitality is Cooper's 2-week lens. It's their 3rd generation SiHy material and available both for sphere and astigmatic correction. Johnson & Johnson is now called Johnson & Johnson Vision due to AMO acquisition. And just like their 2-week Oasis astigmatic lens, the ACUVUE Oasis 1-day for astigmatism with Hydrolux is also a blink stabilized design. So what this does is it allows the lens to work naturally with the eyelids, keeping the lens in the correct position. So patients don't have as much rotation with the lens on their eye. With this stabilized design, it minimizes lower lid interaction. Patients have improved comfort. Patients who do well with this, I find, is someone who may need a spherical lens on one eye and astigmatic correction on the other. They really don't notice the difference between the two. This lens will be available to order through the ACUVUE Educational Sampling Program as of June 15th. It provides wide coverage for astigmatic patients around the clock coverage and low minus through -175 astigmatic correction. These lenses have the highest level of UV protection, and it contains the Hydrolux technology. The Hydrolux technology has tear-like properties that work with your natural tear film, and it's throughout the entire lens. It's not just a coating. Another benefit of the Oasis 1-day lens is they have enlarged optics. So these are great for those patients who have large pupils and those patients who have problems in low lighting conditions. It also has a larger overall diameter of a 14.3 millimeters to help ensure full limbo coverage during blinking. If you remember the 1-day ACUVUE Divine, it's an enhancer. It adds natural looking definition to the limbo ring. The design is built on the 1-day ACUVUE Moist brand, but now the parameters are extended up to a -9. Vita is J&J's monthly lens. It has 2 base curves and has the HydroMax technology. This is to help maintain and maximize hydration throughout the lens so that patients have comfortable vision all month long. It also has a new Infinity Edge design. It's a smooth tapered edge profile to keep the lens more comfortable. J&J has some great resources. They have parameter cards. They re-released their new clinical grading scales with SLAMP techniques, as you can see here. If you don't have these, you may want to reach out so that you can get these for your clinic. They have fitting guides, and they have simulated near-point cards to simulate real-life reading material for your patients. So that was just a brief overview on what we've seen this past year, and there's more to come. The MyDay toric is scheduled to be out later in 2017. The Biofinity toric multifocal is also in the works. I think that we're going to be seeing more on the topic of myopia control. The Natural View one-day multifocal lenses by VTI have been around for the past couple of years. It's a distant center design. It's fit similar to a single vision spherical lens. It has one base curve, one diameter, and one universal add, and it can accommodate up to 3 diopters of equivalent near power. We will hopefully hear more about this as well as the MySight one day from Cooper Vision. Some of you may have heard about Tangible Hydropeg, which is a 90% water peg-based polymer mixture. It's permanently bonded to the surface of the contact lens. It was recently FDA approved. It encapsulates the lens, creating a mucin-like wetting surface. This is great for patients with poor surface wetting of their contact lenses and dry eye issues. What this does is it improves wettability, surface water retention, and reduces tear breakup time. And this may be applied to any contact lens. We currently are able to order it on GPs, hybrids, scleral lenses, and I expect to hear much more about this coming year. This past weekend, we heard that Bausch & Lomb has launched Renew Advanced Formula Multipurpose Solution. They report that the new formula kills 99.9% of germs and delivers up to 20 hours of moisture. This new formula will be the only Renew solution on the market. It will be replacing Renew Sensitive and Renew Fresh, and we will see this beginning actually this month in major retailers. So that concludes my presentation. I'd like to thank you for your attention, and now I'll hand it over to Dr. T.
Thanks, Dr. Harthen. Good morning or good afternoon, everybody. Thank you for being here, and thank you to the ASCO committee members for this invitation to participate in this forum. I will be addressing pediatrics and binocular vision updates as they relate to media use. My presentation will focus on two common clinical questions that I receive from parents who bring their children into our pediatric services. And that has to do with how much media should children be exposed to, and the effectiveness of video game format for amblyopia treatment. Media use has come a long, long way very, very quickly. In my lifetime, we went from watching only what was on at the moment on the limited channels of our television knob to anything, anytime, any day. Yikes. I've never heard my son say there's nothing good to watch, since there's a perpetual marathon of shows at his fingertips every day if I allow it. Now, could a marathon of Sesame Street or Bill Nye the Science Guy really be bad? Well, everything in moderation is a motto I love, but is that statement really evidence-based? Let's see. How much literature is out there regarding media use in children? It's a hot topic, so a lot. But in a 5-minute summary, let's start with the evidence-based recommendations from the American Academy of Pediatrics. The AAP published its first media use policy statement in 1999, but that was not even in the age of smartphones. Does StarTAC ring any bells to any of you? So the recommendations basically addressed television and movies. Now, our lives changed in 2007, didn't it? Between the eye sitter, which Mr. Jobs holds right there, and Baby Einstein videos, we had an entire generation of infants and toddlers being exposed to media very early. So in 2011, a revised policy statement was necessary, specifically addressing media use in children under 2. Now, the most recent guidelines address the entire pediatric age range, but it took 3 papers to present the ever-growing body of research on media use and health issues related to media use. So let me quickly hit the highlights of the recommendations I present to my students and parents. The 1999 policy statement was very short and presented research related to 6 concerns I list there associated with media use in children. It did acknowledge some benefits of educational programs, and it concluded with several recommendations directed at healthcare professionals. As we know, Complex information is often transferred in sound bites by the media, so it shouldn't surprise us that one of the 9 recommendations, and the recommendations were like, become educated on the effects of media, incorporate questions about media use during exams, educate parents about media use, be a good role model should you have a TV in your waiting room, stuff like that. But one point, which was meant to urge parents to discourage television watching for infants and toddlers under 2 years old and encourage direct interaction with caregivers, turned into a rigid no media for any children under 2 years old directive. Well, flip phones are limited in infant and toddler entertainment values. But by 2007 and then 2010, new devices permanently changed the way children entertain and learn. Now, my son was born in 2009, so I lived this dilemma. Should my 10-month-old really not have this awesome iPad? I mean, he can't talk, but look how well he finds the hidden cow and swipes through the pictures. He must be a genius. So for parents such as myself, the revised policy statement was necessary. In it, the AAP reaffirmed the recommendation that children under 2 should be discouraged from media use. They explained that there were significantly more potential negative effects in the research than positive ones for this age group. So there was emphasis that unstructured, unplugged play was critical in allowing young minds to grow, problem solve, think innovatively, and develop reasoning skills. And as healthcare professionals and teachers, I think it's important to explain this to all our young patients during our eye exams, whether we are asked specifically about them or not. Now, can media use in infants really be negative? Well, let me just go over one example. Last month, researchers presented evidence for an association with handheld screen time in infants and delayed development of language. Does it prove cause and effect? No. But this is the type of information that continues to be revealed in research, and we will hear more about this type of stuff in coming years. So what do we tell our parents who asked for our guidance in 2017 in this age of electronics? The good news is we have extremely current evidence-based resources today. In the August policy statement, evidence supports an association between virtual violence and real-world behavior in children. However, it's important as healthcare professionals we understand associations can easily be twisted. Now, virtual violence is not proven to cause real-world violence. Research can only associate virtual violence with real-world aggression. Violence, aggression, what's the difference? There is. Aggression is behavior with intent to harm or intimidate, like a snarling dog or a screaming avatar. But violence is when that aggression crosses the line to physical harm, such as injury or death. Now, research with real-world violence has not been conducted, obviously for ethical concerns, and we need to avoid equating unscientific opinions and industry marketing tracks with peer-reviewed and vetted scientific research. The next 2 policy statements are quite comprehensive and address 2 separate age groups. So let me bullet the points I have found useful for parents in this next slide. For babies under 18 months of old, we want to avoid the use of screen media other than video chatting, and it's for the same reasons we explained in the first 2 policy statements. Now, research shows that there's a developmental shift in attention to televised programs that occurs between 1.5 to 2.5 years of age. So for some children who are ready, those who want to introduce digital media at 18 to 24 months of old should choose high-quality program when they do so. And parents should not feel pressured to introduce technology early for fear that their child will fall behind digitally, because the benefits of direct interaction with adults and learning during unstructured playtime is unquestionably critical to development over media teaching for this age group. At 2 to 5 years, media time should be limited to 1 hour a day of quality programs, and parents should co-view media with children at any age in this age group to help them understand what they are seeing. Letting children use media by themselves should be avoided. We should avoid fast-paced programs, turn off the TV when not in use, avoid media as the only way to calm down our children. In older children and adolescents, media has become an integral part of entertaining and learning, so it's a part of their lives. However, we should place consistent time limits on the time and the type of media that our children spend their time looking at. We have to make sure that the media does not take the place of adequate sleep or physical activity. We should limit media before bedtime, and we really should designate media-free times and zones together. Just like we do in day-to-day life, we have to teach our children about safety online and about respect online. While this forum is too short to present too much detail, you will notice that my slides have references for you, and I'm very happy to share whatever I have with you via email as well. My second area of update involves the incorporation of electronic devices into amblyopia therapy. The exciting research of recent decades have been about various forms of occlusion therapy. And as Christine Hopkins beautifully summarized for us last year in her updates, occlusion works. But is it the cure for amblyopia? Does it work for every child and for all severities and all types of amblyopia? Do our patients like it and comply? Not quite. So what is the exciting direction amblyopia researchers are headed today? Well, again, Christine thoughtfully questioned last year, are we seeing the end of the patching era? Well, researchers are more recently leaning towards describing amblyopia as a two-eye disease where the binocular dysfunction is the primary deficit and the monocular visual acuity loss is really the secondary deficit. So the research today investigates two-eye treatments. And the recent advances of technology has allowed gaming programs to become so advanced with resolution surpassing normal acuity and the ability to control stimulus separately between the two eyes. All these advances have supported our ability to address this hypothesis. I'm going to present some studies now very briefly. This cohort study used anaglyphic glasses. 75 children ages 4 to 12. 25 in sham and 50 in binocular, although 6 were dropped out. About half the children received patching at the time as well on a different time of the day because patching is really a proven effective treatment. So to ethically keep children from that at this point when we don't know that iPad treatment is as equivalent wouldn't be appropriate. So about half of the children receiving patching, however, and the iPad treatment was given 4 hours a week for 4 weeks. There was an option of 4 extra weeks, and you will notice that whether there was patching or not, the binocular iPad treatment rapidly improved visual acuity, and they did a 3-month follow-up after cessation of treatment, and that visual acuity improvement was stable. This younger cohort study that came out of Eileen Birch's lab also found that binocular iPad games were effective in treating amblyopia over sham or non-dichoptic gameplay. So it's not simply the game playing that may be improving VAs, rather the forcing of the two eyes to work together during gameplay, whether you're using dioptic viewing or anaglyphic glasses, perhaps it's forcing the two eyes to work together that is resulting in this improved acuity. When you hear the term iBit, that's going to refer to interactive binocular treatment. This RCT looked at the iBit complementary with patching. So 50 kids aged 3 to 10 years old, 25 received patching alone, and 25 received patching with the iBit. They did 20 minutes 5 days a week within a month, so about 6.5 hours total. And what they found was that there was improvement in both groups, but more improvement in the iBit group. However, after a month, there was no significant difference. So is this improvement just transient? This beautiful RCT iBit study had 3 arms. The iBit game arm, which means it's interactive and binocular. The non-iBit game group, which is interactive but not binocular. And the iBit DVD, which is just a video, so it's non-interactive, but it is binocular. So the treatment was given for 30 minutes a week for 6 weeks. And they found that VA improved in all 3 arms. However, there was no difference in the iBit DVD and the non-iBit games group versus the iBit games. However, the treatment duration was short, and there was a high proportion of subjects that were previously treated amblyopes. So while the study wasn't able to answer if iBit treatment is effective, it is safe and an acceptable form of treatment for amblyopia. Last year, Christine introduced this study to us, but the data had not been published, so she was unable to present the results at the time. PDIG completed a non-inferiority study comparing the iPad to patching head-to-head. While the primary non-inferiority analysis was indeterminate, so it means the statistics did not allow them to state that the binocular iPad gaming was inferior to patching. Post-hoc analysis did suggest that the VA with this particular iPad game was not as good as 2 hours of patching. Now, to be honest, we participated in this study, and I myself would have rather patched for 2 hours than play this boring version of Tetris for an hour. So now the direction is to use more interesting games. This RCT used a much more interesting binocular game called Dig Rush. I've tried the game, and it is more engaging than Tetris. So this study demonstrated on a small scale that Dig Rush was effective and more effective than patching when played for 2 weeks. So given this positive result, a larger scale and longer treatment duration study is currently underway and in recruitment by the PDIG researchers. So we definitely look forward to those results in coming years. In conclusion, this is an exciting time for amblyopia research and app writers too, to be honest. But our leading researchers are on board with investigating binocular therapy. Sue Berry describes how seeing 3D is fundamentally different than seeing with one eye. Dennis Levi says the time may have come to reevaluate patching as a standard clinical approach. Robert Hess feels that rather than emphasizing patching, which may disrupt binocular functions, it may be preferable to reestablish binocular function in stereopsis. Eileen Birch says unless the binocular function is treated, abnormal binocular vision may result in residual amblyopia and may trigger recurrence of amblyopia. So with this kind of brain power behind this area of research, there can only be much more exciting things to come in the next few years. And now I will hand it over to Dr. Morelli.
Good afternoon, and thank you for having me on the program. I'm waiting for this short delay in the slides to catch up with me. I'm going to start my 12-minute glaucoma update with some good news. So while glaucoma remains a leading cause of blindness throughout the world, we seem to be doing a little better job at keeping people from going blind from the disease in the United States. This information comes from a unique epidemiology study in Minnesota, which found that the 20-year probability of blindness in patients diagnosed with glaucoma between 1981 and 2000 was about half that of patients diagnosed between 1965 and 1980. My guess is that there are several reasons for this drop in blindness, including more sophisticated diagnostic tools, as well as better medication and surgical options. So there is some good news about glaucoma. There are a lot of areas that I could focus on for this update, including some new medications that have made it pretty far down the pipeline and which we may see on the market in the next few years, new drug delivery devices that may enhance patient care, and minimally invasive surgical techniques, but I decided to focus on the newest diagnostic tools using OCT, in particular that of macular imaging. So we've known for about 100 years from post-mortem eyes that the macula becomes thin in glaucoma, but that thinning is not clinically detectable with a 78 diopter lens or direct ophthalmoscope. In 1998, Zeimer and co-workers used a research-based scanning laser to image the central 20 degrees of the retina of glaucoma patients, and they found large losses of macular thickness that correlated really well with visual field loss and clinically visible retinal nerve fiber layer loss. But that was still an instrument that was not available for clinical use. Fast forward to commercially available OCTs, and in 2003, David Greenfield measured average macular thickness in normal patients and glaucoma patients and found that the average macular thickness was significantly associated with visual field parameters such as the mean deviation and the pattern standard deviation. And his work suggested that measuring macular thickness might be a surrogate indicator for retinal ganglion cell loss in glaucoma. Of course, now we have spectral domain OCT, which gives us the ability to segment the retina into layers more precisely. And a lot of the work currently being done on macular imaging in glaucoma comes from Don Hood at Columbia University. And they have done a lot of investigating of a segment that they call the RGC+, which is ganglion cell plus interplexiform layer in the retina. And they've described what they call the macular vulnerability zone. So this is an image from some of Don Hood's work, and we've known for a long time that the most common location for injury to the optic nerve in glaucoma is the infratemporal rim. And so this group of researchers mapped that area that's commonly damaged in glaucoma back to its corresponding retinal ganglion cells in the macula, and they found that the most likely site of damage in glaucoma is this area temporal and just inferior to the fovea. This is the area that they're calling the macular vulnerability zone. Now that doesn't mean that patients can't have their first damage superiorly. Certainly we see patients who have superior rim loss, superior thinning, and inferior visual field loss, but in their research this was the most common area for damage in glaucoma. Now all of the commercially available OCT instruments have some type of glaucoma-specific macular imaging protocol. This is a table from an article in Technology Today. It's actually several years old, so it's a little bit out of date, but I put it here just to kind of show some of what the more common instruments have. So the Optotive instrument, for example, does something that they call the ganglion cell complex analysis, and that includes the ganglion cell layer, the interplexiform layer, as well as the nerve fiber layer in a ring surrounding the fovea, and they compare that thickness to a reference database of patients who don't have glaucoma. If we skip down to the Serous OCT from Zeiss, they call their macular scan the ganglion cell analysis. It's derived from the macular cube scan. In this case, they also compare it to a reference database, but unlike the Optotive, they eliminate the nerve fiber layer, and so they're only measuring ganglion cell interplexiform layer. And then the Spectralis OCT does something very different. So they actually use all of the macular layers, and they do a very sophisticated posterior pole asymmetry analysis. So this is an example of how the Optotive scan looks, and this may be slightly outdated, but it's still very similar to what the instrument looks like now. So we really expect to see a pretty uniform thickening of ganglion cell interplexiform and nerve fiber layers surrounding the fovea, and then there will be some type of map that will show us deviation. So these darker colors show us where this patient's ganglion cell complex is a little thinner than expected. And then over on the right we have the significance map, which gives us those stoplight colors that we're so used to seeing, reds, greens, and yellows, telling us about the statistical significance of what we're seeing. Now this is an example of a Serous OCT from Zeiss. This is one of my glaucoma patients, and again we expect to see a relatively uniform ring of yellows and reds surrounding the fovea, and in this example the patient has significant loss of ganglion cells in the left eye in the infratemporal sector. So you can see here, just like we see oftentimes asymmetry between the superior rim of the optic nerve and the inferior rim of the optic nerve, we see this very distinct superior-inferior asymmetry. When we look back up at the thickness map, you see this, this has sort of been termed the squeegee sign by a mentor of mine. It looks like you just took something very sharp and just swiped down on that ganglion cell. This is a really characteristic appearance of early glaucoma in this particular scan protocol. And then this is the Spectralis posterior pole asymmetry map. You'll see that this is an 8x8 grid that's centered on the fovea, and the instrument does an intra-eye symmetry analysis. So that is a superior versus inferior within the right eye, and then a superior versus inferior in the left eye analysis, as well as an inter-eye. So here we have right-left asymmetry, here we have left-right asymmetry. Michael Sullivan-Mee has done some research using this scan protocol and was able to demonstrate that inter-eye, right-left asymmetry of 5 microns or more, or intra-eye, top-bottom asymmetry of 9 microns or more, has a very high diagnostic sensitivity in early glaucoma. And that's really important because there's some question about whether OCT really helps us diagnose glaucoma in the very early stages. And he was able to show that this macular protocol can actually do that very well. There are some advantages of macular analysis compared to the traditional peripapillary retinal nerve fiber layer analysis. So first of all, the macula contains about 50% of retinal ganglion cells, and since glaucoma is a disease of retinal ganglion cells, it makes sense to look where they're most plentiful. Secondly, the macular measurements are more reproducible and there's less anatomic variation compared to the optic nerve and peripapillary area. I always ask my students to think about the last 10 optic nerves that they've seen and think about the last 10 macula that they've observed. There's obviously a lot more anatomic variation in the optic nerve, and that makes it difficult from a scanning standpoint when we're comparing to a reference database. And finally, there's better symmetry of the macula compared to peripapillary nerve fiber layer. Of course, there are always caveats, and with macular imaging in glaucoma, the results are easily confounded by concurrent macular disease. In my clinical experience, epiretinal membranes are the worst, and epiretinal membranes really make the macular OCT pretty much useless in glaucoma diagnosis. Other types of macular disease, including any type of macular edema, also limit the usefulness of this technology in early glaucoma diagnosis. So the interest in imaging the macula leads to an interesting direction in terms of visual fields. If you'd asked me 10 years ago if I thought a 10-2 visual field was helpful in glaucoma, I'd probably have told you that, sure, when a patient has advanced glaucoma and most of their 24-2 or 30-2 is black, there's a little bit of central vision remaining. It may be useful to do a 10-2 to follow up on that very little remaining vision. And that's still true today, but now there's new interest in the 10-2 test pattern in early glaucoma diagnosis. And this comes from the fact that the 24-2 and 30-2 test strategies use a 6-degree test grid pattern, and most of those points on those tests will fall outside of the densest region of ganglion cells in the macula. The 10-2, on the other hand, spaces the test points only 2 degrees apart and more heavily samples this dense region of ganglion cells. So again, I'm going to show you another image from Don Hood's work, and I want you to concentrate on this central image. So we have a fundus photo with a ganglion cell complex or ganglion cell analysis OCT superimposed on it, and then a 30-2 visual field test grid superimposed on top of that. And so you can see that in a standard 24-2 or 30-2, you would only get 4 points testing in that very dense region of ganglion cells. And if we move over to the right image, we see a 10-2 test grid superimposed on just that central part of the retina. And so you can see there's a lot finer sampling of that high density ganglion cell area in the retina with a 10-2. So the idea here is that a patient who has a relatively normal 24-2 test but shows some macular ganglion cell loss on their OCT, that may be a patient that you want to try a 10-2 visual field on. I want to be very clear that this doesn't negate the importance of the 24-2 test. So there are lots of glaucoma patients, probably most of them, whose first visual field loss is seen as a nasal step that occurs significantly outside the central 10 degrees. And so if we abandon the 24-2 and only run 10-2s, we're going to miss a lot of early glaucomatous visual field loss. But one thing to consider is that when we're looking at a 24-2 or a 30-2, we're usually looking for a cluster of 2 or 3 or more points to consider it of any significance. And with this new interest in macular ganglion cell loss and central vision loss, it may be time to look at individual points with more emphasis if they occur in the central 10 or 15 degrees of the visual field. So a single point that's depressed that we might have overlooked in the past, if it's occurring in that central 10 degrees, especially if it correlates with some macular thinning that we see on OCT, that's a patient who probably does need to have a 10-2 visual field. And finally, this has led to a new test strategy on the Humphry field analyzer. I was speaking to Mike Patella from Zeiss about a month ago, and he told me that this was going to be rolled out sometime this year. So I don't know, it's possible that it's already been rolled out. But what they're doing is they're taking the standard 24-2 and standard 30-2 test grids, and they're adding 5 points in the superior and 5 points in the inferior field in that central 10 degrees. And that will allow us to better sample that high-density ganglion cell population. Of course, if you use an octopus perimeter, the octopus perimeter has a completely customizable test grid, so you could set up your own version of that new test strategy that Zeiss is about to introduce. To summarize, this macular damage in glaucoma is common and it can occur very early in the disease. We've always thought about central vision being spared until the end of glaucoma, but research has shown that this macular damage can occur very early in the disease. And it's important to remember that this damage may be missed or certainly underestimated if we're only using conventional 24-2 or 30-2 visual field testing. Before I hand it back over to Stephanie, I'll just close my presentation with an update on the clinical guidelines. I thought I had a slide on this, but I don't. The American Academy of Ophthalmology clinical guidelines on glaucoma were updated in 2016. The AOA's practice guidelines on open-angle glaucoma were initially written in 1998, were most recently revised in 2010, but remember that all of the original AOA guidelines were consensus-based, not evidence-based. The AOA is actively working to transition all of their guidelines into evidence-based guidelines, and the committee for the guidelines on open-angle glaucoma has been developed, and we are starting to work on those guidelines, and they should be completed by the year 2019. So that concludes my glaucoma update, and I'll hand it back over to Dr. Klemenczyk.
I'm just going to wait a minute, too. I've just got a little delay on my slides. But while we're waiting for that, just thank you, Dr. Morelli, and to all of our presenters for session 1. And here in just a minute, we should have a slide that should come up that will show our presenters' contact information. I know I've had a few questions pop up. Here we go, right there. Just asking if there are questions or questions about resources from the various presenters. This is the contact information after the event that you can reach our presenters at. At this time, we will be taking questions, but if you want, this time can also be used as a stretch break between sessions. If anyone has any questions right now, as a reminder, feel free to type them in. We have had just a couple come in. The first question is for Dr. T. And the question is, could you give some examples of what are considered high-quality media programs for children?
Okay. So high-quality media programs would be something like Sesame Street, programs where they are being developed with pediatric psychologists, or there's some research that goes into whether the content is appropriate for the age in which the audience it's directed towards. Does that help?
Yes, thank you. And then we have one question for Dr. Lighthizer as well. And the question is related to, have you noticed any trends, or is there anywhere in the U.S. that's looking at optometrists being allowed to do procedures such as LASIK or other laser eye surgery?
Well, if you're talking on top of, the typical, the law right now in Oklahoma, Kentucky, and Louisiana reads anterior segment laser procedures, excluding refractive surgery or LASIK. You can't introduce a blade into the eye. I'm not aware of any other states looking at LASIK specifically. In Oklahoma, we can do PRK. That requires an additional certification. I don't believe Kentucky or Louisiana can do PRK. I'm not aware of any states looking at laser procedures on top of what can be done in Oklahoma, Kentucky, or Louisiana. But like I said earlier, there are, again, over a dozen states that are formulating a plan for the next few years to try to get the laser procedures in their state that Oklahoma optometrists, Kentucky, and Louisiana optometrists can do.
Okay, thank you. And I believe that's all we have for now. It looks like our speakers did such an amazing job that they don't need a lot of points of clarification. So I'm going to go ahead and do our first, or I guess really our second reminder of the day. Just to remind everybody, coming up there'll be a link that will be shown to go to our Survey Monkey evaluation to give us feedback on this program. And then I believe that link also will be emailed as well after the event. So if you could please give us feedback, we'd really appreciate it. And this concludes our session 1. So I'm going to hand it over to Dr. Oz Motherly from the Arizona College of Optometry, who is our moderator for session 2.
Okay, thank you, Dr. Klemenczyk. As she mentioned, I am Dr. Kayla Oz Motherly, and I'll be moderating this section. The next portion of our program is going to be focusing on clinical ethics, industry relations, and conflicts of interest in education. For this session, our speakers are Dr. Fraser Horn from the Pacific University College of Optometry. He will be discussing ethical issues in clinical education. We are also pleased to welcome Dr. Brianne Hobbs from the Midwestern University Arizona College of Optometry. She will be presenting on industry relations and conflicts of interest in education. We have reserved time at the end of this session after all speakers have presented for any questions. Please use the question box on the webinar control panel to type in any questions you have for our presenters. The end of the session will also be used as a stretch break between the sessions. And up first, I am happy to welcome Dr. Horn. So I will hand this over to him.
All right, thank you, Dr. Asmali. I appreciate it. I appreciate being on the webinar as well. So I'm just making sure we can let the slides catch up to me here. Nope, that's me. So I'm going to talk to you a little bit about ethical issues, and I also have to thank Dr. Ken Eklund because he and I teach a medical legal, actually a medical ethics course here, and so him and I have had a few discussions on this, and really ethical issues we deal with every day when we're in clinic, and I'm not going to be able to hit all of these obviously, but I'm just going to pose a few questions that may spark just some conversation and some thought. So we're really going to talk about informed consent and autonomy. So my warm-up question, I like to give these to my students often, is as a clinic attending, do we inform our students about what to do if the patient refers to the student as a doctor? These are, again, small little ethical issues, but something that I think is important for us to have a discussion with our students about. So scenario 1, it's the first patient a student has in clinic, and ultimately I know it seems like the horror stories that we get or that we hear about from our students are those first patients that become very difficult and often a little more than what a entering student is prepared for. So this one's a red eye patient. You can kind of see the picture there, nice little foreign body there. The attending says that the student can take it out if they would like. and I'm going to tell you that I'm not going to give you necessarily my personal views on how these are handled, but more of post questions and let you think about it. So the attending does come in to supervise. Now the question I have for all of you is, and for you to consider, is what should the intern tell the patient before they do anything? And this really leads us to informed consent. We need informed consent for medical treatment, participation in research, and for participation in teaching exercises involving students and residents. This is really out of respect for the patient as a person and support of the patient's freedom to make decisions, and also allows the patient to be actively involved in their medical planning and care. Ultimately, when we have informed consent, assuming that we're giving them true, full informed consent, this facilitates communication. It should be looked at as a process in the grand scheme of things. And it's a commitment to provide medical benefit to the patients. There are obviously legal requirements, and often there are policies within your own practices, within your own programs that we have to be aware of regarding informed consent. But there's two major elements, and that is comprehension. So the patient has to understand really what's going on and have the ability to understand, and it's free consent. This is all, it should be voluntary choice. So if this patient who has the foreign body gets informed consent from the student, or the student explains informed consent and the patient says, no, that's okay, that's their voluntary choice. They can say no, they can refuse the student from doing it. So for the foreign body patient, my question is, should a student tell the patient this is their first time removing a foreign body on a, and I should put in quotation marks, real patient? I know the various schools have different ways of assessing or practicing foreign body removal. But do we tell them it's the first time? And I brought this up more because it truly is part of that informed consent process. And I'll talk to you about a study here in just a moment. But some of the barriers for not informing about inexperience in clinic, one, it just feels awkward, right? Going from our students who have learned this new language of optometry, they're used to talking with their classmates that understand the language. Now they have to talk with the public, and sometimes that does not come across as well as they could. So it does sometimes come across a little awkward. Their biggest fear, though, is that the patient's going to say no, and that's understandable. So how can we overcome the barrier of awkwardness? Often it's practicing how we give informed consent. The more I talk to my students about, practicing this not with their fellow students, but talking with maybe significant others. But as you know, most significant others know the lingo pretty well. So often talking with parents, other individuals, but practicing that over and over, practicing with their attending doctor, getting that feedback from that doctor, and really going in and observing our faculty give informed consent, to me is huge. I know when I was a student and also during my residency, that ability to observe and then borrow what works well was key to my success. Discussing your inexperience, this may be helpful for the patient because they'll probably notice that the student is nervous, and the student may feel better once the inexperience card is on the table, but it may not. So here's what there's a study that was done in Britain, and they looked at new medical students in the ER, and they talked to them about they looked at the patient's willingness to consent. They did discuss that the attending doctor would be there during the procedure. So what they looked at is how many patients knew that at a teaching hospital they could be the first patient for a medical student to perform a procedure. Basically half of them, which is fascinating in a way if they know that they're going to a teaching hospital. So, and I know our patients are probably the same way, where they just assume they're going to a clinic, they assume they're going to see the doctor. So some of it's also describing to that patient that they are at a teaching clinic. How many patients felt they should know it was the first student's or the student's first procedure? 2/3 of them. So your patients want to know, our patients want to know if this is the student's first procedure. And how many said they would not mind being the first patient receiving supervised procedures? 90%. So most of them were fine with it. Then what they did is they actually looked at how many truly did consent. And they only did it for 3 different procedures: IV placement, splinting, and suturing. And you can see the results there. 90% of patients consented when they were told that it was the student's first time doing the procedure. So kind of interesting because I don't think it really impacted it as bad as what they think. So what I look at is, what if the foreign body patient did not have a foreign body but a misdirected eyelash and needed ablation? This kind of gets at the point of, depending on the procedure and the relative risk, we may be more or less willing to provide that, hey, it's my first time. So it may change our outlook on what they may tell the patient. What I think is a good discussion to have at each of our programs is, how much should our students be providing informed consent? Should we, and I know it's tough because often we're attending for 3 or 4 students, but ideally when they're new students, which this is a good time for a lot of our programs because we have new students, our faculty should be in there listening to how they're giving informed consent. But should they be by themselves? That's a big question. Are there procedures that students can give informed consent and we should not have any concerns, such as entrance skills and that? And really what this then leads to, it's the autonomy in clinic. How much oversight does an attending need to provide for their student concerns? And this is a topic that comes up regularly based off of CMS compliance and other topics, but really my bet is that at many programs and also at many externship sites, the amount of oversight is variable. I know when our starting students go in, our faculty are looking over them constantly. I know that we've received an email from an extern who said, boy, this one student has been one of the best students we've ever had. They're already seeing patients by themselves, which makes me cringe. So there is this big amount of autonomy that's in there, and I think that is a large discussion, which ACOE is now starting to get into, but it does become quite an ethical dilemma in the grand scheme of things. So, sorry, I went too fast. So for me, the question to everybody also becomes, does attending an oversight or rechecking results depend on the procedure being performed, the level of the student, and really what type of insurance do they have? So ultimately, we have ethical dilemmas every day, and we have ethical dilemmas that you do not necessarily encounter in private practice. I'm not too sure about all the other programs, but I know here at Pacific, it's not necessarily a formal discussion that we've had yet. Probably needs to be a more formal discussion in the grand scheme of things. So it's really up to you and your program to discuss how to handle these unique situations. I know that they depend on the variables, but really it should be discussion and then a sharing of the best practices of what's done. So I appreciate you keeping up with me, and I'm now going to go ahead and hand it over to Dr. Hobbs.
Thank you, Dr. Horn. I'm honored to have the opportunity to speak about conflicts of interest today. As Dr. Horn said, my name is Brianne Hobbs, and I'm an assistant professor and residency director at the Arizona College of Optometry. Just a little delay in the slides here. So like most other things in my life, I feel that my self-perceived level of knowledge about conflict of interest has decreased fairly linearly with time. In 2011, I finished my residency at Kansas City VA, and I felt that I knew a lot about a lot of different topics, including conflict of interest. I saw it as a very black and white issue at that time. Industry influence was potentially bad and thus should be avoided. Over the next few years, as major life events occurred, I realized that now I know a very little bit about a very small number of topics. You can see that 2015 was a particularly humbling year as I got married and had my first child within the same year. So my thinking of conflict of interest has also evolved because as educators, we wear a lot of different hats. We're researchers and teachers and clinicians and administrators. And industry relationships are interwoven among all of these roles.
So conflict of interest is a buzzword that's everywhere right now. Doctors in industry, obviously this is a necessary relationship, but it's also a delicate one with high stakes. So several studies have focused on medical doctors, but the relationships within optometry have largely been left unexplored. Medical students and optometry students are even more vulnerable when attempting to navigate industry relationships because of confounders like significant debt, inexperience, and lack of instruction. Is conflict of interest a problem in optometry? When we look at these stats from 2014, which were gleaned from the CMS Open Payments website, I think we can agree that this potential issue is relevant to optometry, as $18.3 million in payments were made from industry to ODs. This consisted of 165,000 transactions made to over 36,000 optometrists. And yes, that's almost every optometrist in the country, according to the Bureau of Labor Statistics. I think this is a potential problem for optometry. The Physician Payment Sunshine Act of 2010 made public every transaction made to every physician in the U.S., including ODs from industry. So this is a public website, and it's very easy to search for a particular doctor. So this is now public knowledge, and the public can easily see every dollar that you've received from industry. So I do think that this is a topic that we need to be addressing in the optometric curriculum. Focusing specifically on optometric education, a relevant question is, should we, as educators, disclose all conflicts of interest in our lectures to students? I teach evidence-based medicine here at Midwestern, and I think this quote by Dr. Flyer of Harvard Medical School really gets at the heart of evidence-based medicine and critical thinking. Dr. Flyer emphasizes the need to encourage students to think for themselves, to draw their own conclusions, as this is a skill that they're going to need for the rest of their careers. I think disclosing all conflicts of interest cultivates transparency and also gives students all the information so that they can decide for themselves whether they think the lecture material is being presented in a fair and unbiased way. Certainly to some students, affiliation with industry will merely confirm the expert status of the faculty member. But to other students, it may prompt more careful analysis. So what are the benefits of disclosures in didactic lectures? I think that the development of critical thinking is one of the most important skills that we can help students develop. And giving them all the information, including disclosures, and allowing them to interpret for themselves is central to the development of critical thinking. For continuing education courses, speakers must report disclosures. It seems that when you have an even more vulnerable population, students, disclosures are also appropriate. It could be argued that, in fact, disclosures are even more important with students because they're in a critical period in which they're forming opinions which are going to dictate how they practice for the remainder of their career. Now, I realize the third point could be a bit inflammatory, protecting students, but let's think about some of the statistics regarding the forces that shape the way students think. So a few years ago, one of my colleagues, Dr. Neville, and I conducted a survey of fourth-year optometry students regarding their attitudes and exposures to industry and conflict of interest situations. So even though the survey had an abysmal response rate of about 5%, a few statistics were notable. Only 7% of optometry students thought gifts influenced faculty members. And this is in stark contrast to another study in which half of medical students thought faculty members were influenced by gifts. So our students clearly hold us in very high regard. And ultimately, over 90% of respondents in our survey said that their prescribing habits were largely shaped by their clinical faculty. And so this means that we have tremendous power in impacting how our students are going to prescribe and practice.
Finally, in a large study of medical students, 75% desired disclosure from their faculty members regarding conflict of interest. So I think this sentiment is probably transferable to optometry students as well. So a pertinent question is, how can we better prepare our students to more adeptly deal with industry relationships which may present potential conflict of interest situations? First, I want to acknowledge that ignoring the problem doesn't provide a solution. Let's consider a major public health problem in the U.S., teenage pregnancy. The U.S. has the highest rate of teen pregnancy and the lowest rate of contraceptive use among developed nations. So this really provides further evidence that ignoring a problem and failing to address it with adequate resources and education is only going to intensify the problem. Now there is one caveat. Ignoring the problem doesn't provide a solution unless you have a toddler. This is my normally very sweet toddler who was throwing a tantrum because I put his milk in the wrong cup. I think some faculty members might consider instructing students about industry relationships as playing with fire, because there is a lot of gray area and many faculty members may have conflicts of interest. But I would contend that it's better to acknowledge these difficulties and teach students how to negotiate them rather than just telling them to stay away from industry or simply ignoring the situation altogether. I think a great example of this was noted in an article I read a few months ago about a program in Germany that was teaching young kids how to safely start fires and properly handle matches rather than just forbidding any interaction with this lucrative item. I think this concept of empowering the learner is also applicable to industry relationships. As educators, what can we do to better prepare our students? What types of interventions are appropriate and effective? I just really love this quote from my residency supervisor, Tim Harkins, about communication. The first step in effective communication is bothering to communicate. So even if we don't know perfectly how to approach this problem in our curriculum, we at least need to start having conversations with our students about them. So these statistics are derived from the conflict of interest survey I conducted with Dr. Neville of fourth-year students. Overall, students had received very little instruction regarding conflict of interest situations, with the majority receiving only 1 to 2 hours, if they received any at all. 36% received no instruction. This relationship with industry is an important one that they're going to need to navigate for the rest of their career. You can look up the diagnosis of a rare condition, but interacting with industry in a way that doesn't cause conflict of interest is a skill that needs to be developed. It's not simply a fact to be memorized. The overwhelming majority of students, 85%, desired more instruction about how to deal with these potential conflict of interest situations. That's right, the students actually wanted more material. So I think we should pay attention to what the students are saying. So this brings up an additional question. Is formal curriculum even effective in empowering students to negotiate industry relationships? Well, it depends on which outcome measures you select. There's a paucity of research on this topic, and to my knowledge, there's only one small study of optometry students conducted by Dr. Jordan Keith, which evaluated the effectiveness of formal lectures within the third-year curriculum. And ultimately, he found that the formal lectures didn't make a huge impact, but he hypothesized that earlier interventions, perhaps in the first or second year of the curriculum, would be more effective. And on a larger scale, there has been evidence which shows that formal conflict of interest curriculum is effective in causing behavior change. What is always effective, though, is utilizing the silent curriculum. So this term is defined as the informal curriculum, which consists of what we're teaching when we're not consciously teaching. And it's much more powerful than our words. We know that our behaviors shape student behaviors, so we should emphasize evidence-based prescribing rather than sample-based prescribing. What we do in clinic is more impactful than the lectures we give about what we should do in clinic. I would like to briefly discuss a scenario that we encountered here at Midwestern regarding industry relationships and conflict of interest. So historically, the university has maintained a very strict no pharmaceutical samples policy among all of its colleges and programs. A few months ago, we started discussing it, and we felt that samples would potentially help us take better care of patients by providing them with access to medications that maybe they couldn't acquire otherwise. We wrote a pretty extensive white paper on this topic outlining our stance on the matter, and that was disseminated to the other colleges. We felt that ultimately the samples would help us better serve our patients, but also better serve our students by providing them with some education on how and when to use samples. There were multiple issues regarding which patients were going to get to have the samples, how often they would receive a sample, and how we would track the samples. But we established protocols to address the specifics of each of these potential problems. Ultimately, though, the hang-up was the other programs. The College of Medicine and the College of Pharmacy felt very strongly against samples, and here's why. The American Medical Student Association publishes a scorecard about conflict of interest policies for the major medical schools in the United States. There are 14 major categories listed at the right on which schools are graded, and it's fair to say that the standards become more rigorous each year as conflict of interest is going to draw more and more public attention. Criteria are also becoming increasingly stringent. These topics listed at the right are also all appropriate for optometry students as well. Our College of Medicine was opposed to allowing samples because it would impact the scorecard and potentially have a negative effect on recruiting and also on accreditation. So how exactly is the grade determined? Well, the letter grade is assigned based on the number and the rigor of the conflict of interest policies that the colleges hold. Our College of Medicine was very motivated to maintain their A letter grade and felt the sample policy would endanger this ranking. So ultimately, we went to bat for samples. But when it became obvious what a point of contention it was, well, we quietly put down our bat and walked away. There's just a few final points I'd like to share with you today. Industry relationships are necessary. Industry funds research and provides scholarships. And industry has a lot of benefits for us in an academic setting. We can't simply separate our profession from industry, but we need to be deliberate about how these relationships could potentially impact our students. The second point is that there's going to be increased scrutiny on conflict of interest relationships and a demand for increased transparency from the government, from the public, and ultimately from our students. Regulations are probably going to become increasingly tighter, and ultimately a scorecard may be generated for optometry schools as well. And then finally, more formal curriculum on conflict of interest is likely appropriate. But even if there's no room for more formal curriculum, the silent curriculum of our clinical prescribing behavior is powerful. I really liked this quote from an article I read about conflict of interest. and it said, role modeling is in the eye of the beholder. Mentors may not realize they are teaching professional values, and those not seen as mentors may believe they are. This is a testament that it's not our perspective that matters, that rather it's the student's perspective that matters. This concludes my presentation. Thank you so much for your attention, and I'm going to turn it back over to Dr. Osmotherly at this time.
Thank you, Dr. Hobbs and Dr. Horn, for those excellent presentations. If anyone would like to contact either of our presenters, please note their contact information provided here. The next few minutes may be used as a stretch break if anyone needs one, and at this time we will field any questions for our presenters. So we have a few that are noted here, and the first one is actually a question for Dr. Hobbs. So Dr. Hobbs, do you think that faculty are appropriately educated on industry relationships? And if not, what do you think the best way is to educate the faculty on this topic?
Thank you for the question, Dr. McDowell. I think that's a pretty big question to answer. I think overall, there's kind of a lack of education about conflict of interest, both for students and for faculty members. Whenever we were sitting down to discuss the pros and cons of pharmaceutical samples, we first had to figure out what our policy actually was and how long it had been in place. So I think in general, it's just a topic that hasn't been discussed very much. Regarding the best way to educate faculty on this topic, there's not a lot of evidence out there regarding interventions that are very effective. I think one thing that came to light in our survey of optometry students was that a lot of students weren't even aware what the policy of the university was regarding samples. And so I think having the faculty together and making everyone aware of what the policy is regarding conflict of interest and pharmaceutical reps is a good first start. I think it starts a conversation that can then take different routes as more and more topics come up.
Thank you, Dr. Hobbs. We also had a question that was posed to Dr. Horn. Dr. Horn, does the fact that the patient is aware that he or she is in an educational setting make a difference? And I'm assuming this is referencing the informed consent.
Yeah, that's a good question. I think it can make a difference. I think one, I hate to say spin it. Great, that's my phone ringing. One way to look at it is that they are getting care by a student who has learned the latest from the faculty, as well as they're also getting the faculty to look at it. So they get two brains to look at somebody or to help someone. I think it is important to explain that. Often that may explain the reason why they're getting lamps done twice or other things done twice. And I think sometimes it may also explain some of the conversations. So I often will talk to the patient saying, hey, I'm going to talk really briefly about your case with the student in front of you. We're going to explain everything to you, or we're going to talk about the management strategies and how we have to write the referral letter and all that in front of you. So I do think that it's important for us to describe that, yeah, you are in a teaching institution when you're there.
Great. Thank you, Dr. Horn. That was all the questions that we had submitted for this session. So just as a reminder that at the end of the program, please go to our SurveyMonkey link, which will be sent out but is also listed on this slide to provide us feedback on this event. This concludes session 2. I will now hand everything over to Dr. Neil Pence from the Indiana University School of Optometry for session 3. Thank you.
Thank you, Dr. Osmotherly, and thank you to all of our presenters so far. Our next portion, we're going to talk about the challenges of meeting compliance measures with various CMS and third-party regulations, while at the same time being able to provide good patient care and clinical education to our students. As clinical faculty, it can be difficult to stay up to date on the constantly changing topic of compliance. Nevertheless, it's very important for us to understand the current issues and also to be able to teach our students the rapidly changing and evolving healthcare systems. For this last session, we're pleased to welcome presenters from the Michigan College of Optometry, who will be talking about Hipaa security breach that occurred, and also talking about the Macra and the MIPS system that will be replacing meaningful use this year. So at this point, I'd like to turn it over to Ms. Lisa Roach. Lisa, you have the microphone.
Thank you, Dr. Pence. This is Lisa Roach, and I oversee the daily operations of the clinic, the University Eye Center at the Michigan College of Optometry. And up until just a couple of months ago, when I had the distinct pleasure of passing my Hipaa torch, I have been the Hipaa privacy officer as well. My presentation will discuss our experience and lessons that we learned from the Hipaa security breach that affected our clinic. And joining me in our presentation later today will be Dr. Dave Durkee. So what happened? Well, the word breach is a really strong word, and we tend to like to refer to this as an incident that occurred that eventually became a breach. The cause of our incident began on July 13, 2013, when we had a malware program discovered on a computer used to operate the website for Ferris State University. This was a university-wide discovery in which an unauthorized person had actually evaded our network security. Now, we had created within the Michigan College of Optometry a system, a sandbox system for our EHR, so students could use it in our procedures courses for learning. Upon our investigation of this malware, we had discovered that there were actually hidden production files in our sandbox system. In the backbone of that system, we were unaware previously that those had been placed in our sandbox. Now, although we could not really confirm that there had been a breach, the potential for the compromise was there, so our investigation was treated as such, as if there actually had been a breach that had taken place. Immediately we had shut down our network. That was our first step in security measures to ensure nothing further was compromised, if in fact anything had been compromised up to that point. And we enlisted the assistance of a third-party forensics team. Navigant was used to help guide us through this investigation. Obviously, it's not something we had ever been through previously. Now, we spent the next 6 weeks reviewing files with the assistance and guidance of Navigant. We had 60,000 patients in our database, but we had discovered there were only 18,000 claim files. So those were actually the files that were put on our sandbox and that we actually had to manually review. Further mitigation revealed that only 3,947 of those files actually had PHI that could have been compromised. Again, we didn't know that it happened. So we spent the next 60 days investigating, or a total of 60 days, investigating and then filing our report with the OCR, the Office of Civil Rights, on September 24th of 2013. Along with that requirement of filing the report with the OCR, we also had to create a formal press release and post a statement on our website indicating that we had been victims of a security breach. We additionally mailed written notification to all 3,947 patients, and we provided complimentary one-year credit monitoring to those that had information regarding their Social Security number potentially compromised. In order to field the expected numerous phone calls, we set up a communication center to answer questions, and all of our EHR files were tagged with notification that the patient had been involved with this security breach. Now, of course, we didn't know to do all of these things all on our own. We had enlisted the help of a law firm, a Hipaa specialty law firm, Baker Hotsettler LLP. So with all the hours that we spent between our department, our IT department, the lawyers, the forensics firm, there were a numerous amount of time that was spent investigating this information and compiling this information for submission. We didn't realize that was just the tip of the iceberg. The real work was actually ensuring that we had practices put in place to prevent future incidents from occurring, so we would never have to live through this again, ideally. So we conducted our internal investigation into the matter. We rebuilt our network asset and our web server. That entailed rebuilding our sandbox so that it was a fresh copy of everything. We started with just the shell and added files as necessary, and ensuring that we were not putting any PHI back into our student sandbox. We upgraded to the latest operating systems, did some patching, and completed our server hardening. We installed the latest version of application software and patches, and applied the latest version of antivirus and malware on our servers to harden our systems. We also verified that we had removed that ePHI from our sandbox and started fresh. We required that all users that had network access were to change their passwords. Now, this is something that we typically did at the university anyway, but we also started doing this with our iCare CompuLink. No longer could we use that same password we had been using for years and years. Not only did we create new passwords, but it became our practice to renew our passwords every 90 days. We required our database and system administrators to not only change their passwords for the Serous systems, but that they also change their user identifications to, again, strengthen our systems. And we created a formal strategy to strengthen our security system through risk assessments and our work together with our IT security office. They had hired a security office in 2012 who had already started to assess our systems, thanks to the foresight of Dr. Dave Durkee as he was getting ready to attest for meaningful use. So we'd already performed our initial risk assessment, which uncovered quite a bit of information that we could use to strengthen our systems. We also revised our firewall rules to limit the transfer protocol and to limit access from outside sources. So if a website had been identified as potentially malicious, nobody from the inside was able to access that. We blocked their specific internet addresses to our network. We also upgraded our internal and external firewall solutions. That included hardware and software. And of course, we have documentation that we had performed our early risk analysis and began the practice of performing annual risk analysis to ensure that we were doing the best that we possibly could. Back to the time of the breach, we had created a dedicated call center as we expected many patients would be calling in. Although we had this established and it was identified in the letter sent to all of the patients, we had several people still call the University Eye Center because they saw this on the news or they saw this on the website. So we would have our staff, had a script actually created for our staff to direct patients to call the specified number. We, of course, worked to remove all our sensitive data, revised our policies and procedure, which would be included in our new IT security manual, our HIPAA security manual. It addresses how Serous administratively, technically, and physically safeguards our patients' PHI and what our protocols are. We had not had this in place before, so I had the pleasure of writing this fun manual. We also obtained written assurance that FSU employees received the training on our revised policies and procedures, and we brought in an expert Hipaa attorney, Norbert Kuglia of Warner, Norcross, and Judd, to speak to all of our entities on campus. He had been here once before in 2002. We had recorded his session and used that as our Hipaa training. So he provided us with an updated presentation that he allowed us to record, and we continued using as a new training for anybody that was hired into the university. Now this included people from our healthcare entities and from IT, General Counsel's office, and HR. Of course, we also had to post a substitute notification of the breach incident on our website, as I mentioned before. And we did offer free credit monitoring to anybody who had their Social Security number involved in the breach. We documented our policies and procedures related to compliance with the privacy, security, and breach notification rules, and we had created a Hipaa security manual as a result of this breach, but we updated our Hipaa privacy manual that had been created years and years ago and had not been touched since. We also revised our notice of privacy practices to be in accordance with all current Hipaa rules and regulations. And as our final step, we also developed a university-wide Hipaa compliance committee, which meets every 2 months at this time. It includes a representative from our general counsel, a representative from each healthcare entity, as we have several healthcare entities on campus, and members from our data security office, including the data security office and our data security officer, excuse me, and our chief technology officer, and of course a representative from human resources. So lots of hard work, and our result, our case was closed. It was quite favorable. Not only was it closed, but it was closed without a personal visit from the OCR. Best case scenario. We had a potential of $1.5 million in fines based on the number of patients involved in our security breach, and we paid nothing. So basically our voluntary actions of trying to remediate and make our best effort ended up with not facing a penalty from the OCR. In fact, the OCR letter actually stated that based on our foregoing 18 items that I covered on slides 9 and 10, the OCR closed the case without further action effective of the date of this letter, which I would like to mention we did not receive until June 16th of 2016. So nearly 3 years after we filed our report, we sat waiting for them to walk through our doors at any day. So that was quite a long time. So lessons learned. What is some advice we can offer to you so that you can learn from our experience and not face a visit from the OCR yourselves? My number one piece of advice would be to save copies of everything. The OCR wanted copies of our original documents, including the Hipaa privacy manual, the security manual, our signature on file forms, and our Hipaa notice of privacy practices. So our original documents, our current documents, and everything in between. My recommendation would be to save copies of everything, because when you have to recreate and find and dig out and make them all electronic copies so you can submit them, it takes quite a bit of time. So as you're going along the way, I recommend saving those copies. So I get that we're all creatures of habit. As a Hipaa privacy officer, I frequently hear, but I never had to do that before. Yes, I can appreciate that. It's not necessary to change because survival is not mandatory, right? We don't have to survive. And if you don't change, you probably won't. So as I mentioned, maybe once or twice so far, please save copies of everything. It will help you in the long run. Ensuring that your privacy manual and security manuals are reviewed at least annually and up to date is critical. Utilize technology. There's so much technology out there that can secure your systems. Secure your systems and can guard your EPHI so that you don't have to worry. You can protect that with encryption software, firewall settings, antivirus, and software and hardware, and management systems. And then conducting annual security risk assessments. And I recommend using the assistance, utilizing the assistance of outside entities. They have a great perspective. They know what the OCR is looking for, and they are a great benefit. Performing a thorough risk assessment before you introduce any new software or hardware. Our university policy is that a risk assessment must be conducted before any new software or hardware is introduced into our Hipaa environment. Now, it's not just a Ferris policy. This is recommended through the OCR, through the Hipaa. And we actually go through a very extensive research procedure to make sure that the system is compatible with our university hardware and software that is already in place, and then it is tested in a safe environment before it is put to use in clinics. So in addition to this, we've taken some preventative maintenance steps. Right. There we go. Education is key on all Hipaa policies and IT security. So all of our faculty and staff are trained upon hire, and they're required to recertify annually. Additionally, all of our students are trained before they enter clinic, and we try to make sure that student employees, student clinicians, faculty staff, even our custodians are trained annually and retrained annually with Hipaa. We obtain written notification either through their completion certificate or a log form if it's something that I have done myself. I personally come in to train our custodians as they work in the evening, and then I have them sign a log sheet. Even if it's just accidental exposure, or you think they could accidentally be exposed and they're not directly involved with Hipaa in their everyday job responsibilities, it's still important for anybody that is in your area to be aware of the Hipaa guidelines and what to do. So encryption equals protection. PHI should always, always, always be encrypted, when possible, of course. Now, not just mobile devices and laptops, but encrypting clinic computers and even USBs is also recommended. For instance, if you have a USB and it is encrypted and you misplace it, we all know how hard it is to keep track of those pesky little USBs. If it's encrypted and it gets lost, it's not really a big deal because it's encrypted. The information cannot be accessed. So if you are negligent, then you are responsible. It's not just your university that becomes responsible. You are personally responsible as a doctor, as a student, as a staff member. I'd also like to add that email is not a secure method of communication. Fax, however, is secure because that goes through a phone line. Email does not go through a phone line, therefore it is not safe. Now, frequently, we'll have patients request their information to be emailed to them. They want their exam records because they're going to a doctor appointment tomorrow, and they don't want that. They don't want to wait for the information, or they just need to have it, or they have to have it for school. Now, the HITECH Act actually requires that we advise our patients that email is an unsecure method of communication, and additionally, I'd ask that we obtain a confirmation from the patient that they understand that it is not a secure form of communication. So if you have a patient that is desperate to get their information via email, although it is not our office policy to release that information via email, you can have the patient email you requesting this information and acknowledging that they realize this is not a secure method of communication. And as a last tidbit of information, I recommend that you review your hard drive files. I've been employed with the university for quite some time, and I had many, many files willed to me as I took over this position 7 years ago. And when I reviewed my hard drive, I found that there was PHI on my hard drive as a HIPAA privacy officer taking over, because years ago it really wasn't a concern to have that information on a hard drive. So you could have information embedded in files that you don't even realize is present on your computer. I recommend reviewing those files. And at this point, I would like to pass the presentation over to Dr. Dave Durkee. Thank you for your time.
Okay, thank you, Lisa. And it's my pleasure to go on with our presentation, but I will want to say that without the dedication, I'll echo what Dr. Damari has already said, and that without the dedicated work, especially of Ms. Lisa Roach and our staff, our IT staff, our legal department, and everything else, we would not have had the result that we did. And you can look at good case examples, even from Idaho State University, and even as recently as the Dallas Children's Hospital, that also had incidents or breaches, and they did nothing hardly at all to remediate anything. And in fact, recently with the Dallas Children's Hospital, OCR fined them right around $3.2 million for their breaches. And so if you're not going to be proactive about taking care of these things, this is exactly what you're going to have trouble with. So with that being said, what I want to get into is the second part of our compliance presentation, and that's talking about Macra. And as you know, it was passed in 2015, the Medicare Access and Chip Reauthorization Act, and out of that, they created the Quality Payment Program, which replaces Meaningful Use, PQRS, the clinical quality measures, and the value-based modifier all into one system. So I think CMS is really doing at least a great service by combining all these disparate systems into one place so that we have at least kind of one system we can try to monitor. The Quality Payment Program, though, is composed of two different parts. The Advanced Alternative Payment Model is something that probably most, maybe hospital systems and physician groups might be using that are already well established. It's not going to apply to hardly any of the optometrists that work out in the real environment. And I would be very surprised actually if any optometry school actually worked under the Quality Payment Program using the Advanced Alternative Payment Model. So what I'm going to spend most of my time talking about are the merit-based incentive payment system, the alternative way that you can participate in MIPS or in the Quality Payment Program. And I'm going to tell you about how I think that most optometrists, and especially how the Michigan College of Optometry, working with CompuLink's iCare Advantage software, would probably be the easiest path. And I know that many schools use CompuLink's iCare Advantage, so this will be pertinent to you. Those of you that use other optometric-based software programs, EHRs, will be using something similar. Although I do know some of the schools use much larger systems, maybe like NextGen or Epic. And as far as I know, the path that I'm going to lead you down is not as applicable to, say, NextGen and Epic. And so, but they will have their own system of how they're going to try to participate in the merit-based incentive payment system. The other point I wanted to make was that Macra, MIPS specifically, is a little bit different in the quote compliance part of it. You know, with Hipaa and OSHA and working with insurance companies, federal insurance companies like Medicare, you are required to comply with their provisions or you will face penalties, fines, and possibly even jail time. With MIPS, it's not so much as a compliance. If you qualify for it and do well, you're going to get rewarded with a financial incentive. If you don't do as well with it, there's going to be a financial penalty, and that's about it. So it's a little bit different level of compliance. You might say, well, why are we doing this at all? And CMS recognized many, many years ago that the cost of healthcare in the United States was way out of control. And you can see here that the cost for healthcare in the United States is not only much higher than most other developed countries in the world, it's rising at a faster rate. And CMS realized this, and they said there's got to be some way to control cost if we can do this somehow. And yet if we do, if we just plain cut prices or reimbursement rates, we'll reduce the access to care and the quality of care, and we're especially concerned about that too. So that's what's happened. So the United States is like this, and if you look at this graph, you think, well, yeah, but the United States has the best quality of care in the world, doesn't it? Well, not necessarily so. If you look at these 11 countries that are developed countries in the world and look at the overall ranking on the very top bar there, the United States ranks last in the quality of care on these measures that were measured. And right next to the United States is the UK, which ranks about #1 in the world in almost every category. And when you look at their cost being so low and yet their quality is so high, you know, in fact, everybody in Washington would look at it and say that it has got to be achievable. There's got to be a better system. And how you do that in the American healthcare system, working with different insurance companies and everything else. So I think that, you know, besides all the debate that's going on right now in Washington over the healthcare system and the cost of it, that you've got to gain some kind of control on the cost and the quality of it. And I think they do go hand in hand. And so this is the best thing that we can do. I will point out here too that remarkably, the countries that are doing the best at this just coincidentally happen to have universal health coverage. Whether they have a national health plan or not, or a single payer system or whatever, at least they do have universal coverage, so everybody's included in the plan and everybody has certain benefits that they're given. And of course, there's many cultural or social differences, but the big thing is that they're working on it to try to do more preventative care than curative care. And that's the biggest thing and the biggest difference between most of these countries compared to the United States. Now, if you were looking at surgical outcomes and everything else, yes, the United States is probably one of the best in the world. But it's not the best for keeping a population of people healthy with the lowest amount of cost. So that's the whole idea. Try to get better care at less costs. And so optometrists participate in MIPS as physicians. Whatever work you do this year, it started this year, you'll get rewarded or penalized 2 years later. So in 2019, you'll see the fruits of your efforts. And the other thing that's going to happen is you're going to get more and more feedback on the quality of care that you're enabling to adjust these best practices. So you have to find out, are you eligible? And optometric institutions, of course, are unique because there's a few institutions that will have full-time clinical faculty that do nothing but work in the clinic. And it would not surprise me if they were doing that and working the volume of patients that they do every year, that they would be eligible as individuals. And so the AOA lobbied pretty hard really to have both these criteria be met to be eligible, and that you had to have more than $30,000 per year, charge of Medicare Part B claims, and provide care for more than 100 Medicare patients in a year. So you had to meet both of those in order to be eligible. You could choose to be an individual or a group if you wanted to. And that's the one big difference. And I think the place that the Michigan College of Optometry is going to do, because almost, well, every one of our faculty actually only practice in the clinic part-time. And because of that, I've already looked at all the statistics and everything else and the numbers. I knew that none of them were going to be individually in there, so we're going to participate as a group. And there's now some word on the street, and CMS is talking about the building of these virtual groups. I don't know that much about them, but you may be able to get together with other people who are not physically really located that close to you or whatever, and create a virtual group. You know, and when I see that, I think CMS would really love to see you be successful at this system. And so they're trying to do everything they can to get you qualified and participate in it. The unique thing about it, different from the EHR incentive program, is that you don't need to register for MIPS. CMS is just going to tell you if you're eligible or not. If you're not eligible, you can voluntarily participate, but you'll not be able to get any penalties or bonuses. And some people may want to do that just because they want to get used to the system, or they want to be able to learn how to do better practices, and that's fine. If you're eligible, though, the interesting thing is you cannot opt out. You are in the system if you're eligible. Nothing you can do about that. People excluded from MIPS are the ones, of course, that are newly enrolled in Medicare in 2017, didn't meet either one of those two criteria we talked about, either low volume or the low threshold. If you already significantly participate in an advanced alternative payment model, you're excluded. And so if you don't meet any of these exclusions, you are going to be in MIPS. So I told my staff several months ago, because I knew it was coming, I said, tell me when this letter shows up from CMS telling us whether any of our clinicians are eligible or not. And sure enough, it was on my desk within a couple of weeks. I turned around, looked at it, and none of our faculty were individually eligible to participate in MIPS. And as you can see right in the lineup there, I don't know if my mouse is working here, but it says, note, however, that if your group chooses to report as a group, MIPS assessment will be based on all individuals in the group, and payment adjustment will include those clinicians who do not exceed the low volume threshold as individuals. And so that is a voluntary item that you can do if you like. And so actually, I've had my contacts at the AOA, and we're going to talk a little bit more later about AOA more in their registry. But I wanted to know that if we could do that through the registry, AOA's more registry, and they said that we can send our data in, it'll go in as a group, and the data would be recorded as a group. And on this slide, I actually happen to put Danette Miller's email address down, and she's very, very helpful there at the AOA, and they know a lot about how to try to get you to participate in MIPS, even if you don't decide you want to use a AOA's data registry. So why would you do this? Why would you do this as a teaching clinician? Being able to participate just in MIPS, and the financial rewards, of course, are great for the clinic. A more successful clinic is always nice to have. But I think the big thing is really being able to teach students how to succeed in these future pay-for-performance types of systems. Because as you can tell, I think over the years, they've been talking and talking and talking about this, and now they're putting a little bit of their money where it matters, and that trying to get clinicians to be much more responsible and produce quality work that is cost effective. And I think if today's students don't learn how to participate in quality improvement systems, that they're going to be left a little bit out of the place, out of the loop. But it's also, the interesting thing about it is when you start adopting these things, that you'll learn how to work with very good systems, already established systems, of how to improve the quality of patient care, and be exposed to things that maybe hospital systems or other healthcare organizations have worked out over the years. And you may not have been introduced to these kind of ideas. And so we actually are participating in what's called a practice transformation network, and we're getting some assistance from these people who are used to working on trying to analyze your processes to see if you can do them as efficiently as possible and increase the quality or do it at less cost. And anything we can do and will also help the patients out, of course. The disadvantages are is if you voluntarily decide, okay, as a group, we're going to go ahead, we're going to participate. Well, you could participate at such a level you'll actually get a negative financial adjustment. So you're kind of putting yourself on the line a little bit when you say, I want to participate, let's go, let's teach the students how to do this and everything else, and then hopefully, and I'm sure you all will do your best efforts trying to make sure that you get a positive financial adjustment. One thing about the groups too is that CMS will only see the group data, so you're kind of in it all together if you go that way. If you can qualify as individuals and want to stay like that, that's fine. But of all of your individual, I'm almost sure there's no school out there that has everybody working in a clinic would all qualify as individuals. It could be, but I kind of doubt it. And if you do, then you're going to have some of your faculty involved and some of them not. And it's great because at least the individuals that are participating can see exactly where they're at. The ones that don't participate are going to be kind of left out of the system, and it leaves a kind of disparate system in your clinic of trying to work on quality measures or processes. And so that's why I think a group would probably be better for most schools if you think you can go that way. So here's the first year, and they call it pick your pace. I think they're going to do this for this first year. They call it transition year. And before they finally fully launch it a little bit more in 2018. But if you are eligible for MIPS and you decide you don't want to participate, you're going to get a negative adjustment. You can see what happens if you do anything along this path. So don't participate. You're automatically going to receive a 4% penalty. Not that much different than, say, meaningful use, the actual meaningful use incentive program, and then the PQRS, that if you didn't participate with that, you got penalties that are a little less than that, but you still got penalized. Now you could submit something, and that's what's interesting. Everything I've read says just submit something, just submit one measure, just submit a little bit of that, a little bit of that, and at least you'll get no penalty. And you'll learn how to use the system. So if you don't do anything but a little of that, then that's good. And it's one point I did want to make, the difference between MIPS in the EHR incentive program is that in the EHR incentive program, you had a certain kind of threshold you had to meet, and then you got rewarded financially all the money. With MIPS, once you participate and you meet some of the measures a little bit, you can get then rewarded just a little bit. And then the more you do, the more volume and quality that you do, then the higher the reward will be. So it's a little bit different graded system, and the baseline on it is almost right down to 0 instead of the EHR incentive program, which might have been a 10% or 50% rate on some of those measures. So now if you submit a partial year, a 90-day period, and depending on the measures and the outcome, you may earn all the way up to the 4% bonus, the maximum for that time period. Submit a full year, you may earn up to a 4% bonus. And the one thing I did want to point out is that just because you participate for the entire year, which would have meant you would have had to start on January 1st this year, just because you submit a lot of data doesn't mean you're going to get the highest bonus, because it's still much of it based on quality of measures, not just the volume. And that actually goes for a partial year too. So in the future, looking at it, what the work you're going to do in 2017, you're going to see show up. You'll get a statement in the mail at the end of 2018 that'll tell you what your reward or penalty will be for that next year on your Medicare Part B payments in 2019. And then so everything leapfrogs those 2 years. So your work you do in 2018 will then show up as a plus or minus 5% range of bonus in 2020, and so on and so on, the maximum being plus or minus 9% in 2020, and not seen any documents that says what's going to happen beyond that. You may have heard that in some documents it may have been looked at and said, well, gee, I thought I could earn 27% bonus. And there is such a thing as called an exceptional performer, and you'll receive up to, it's a kind of a sliding scale again, anywhere from a little bit over 1 time to a 3 times multiplier and whatever these top percentages are. So yes, in 2022, you could earn a 27% bonus, but you have to be performing at a very, very high level. And so CMS is actually going to look at that and then try to put the threshold somewhere, put the bar somewhere. And I think they're going to keep moving that bar every year as to where it's at and who those people are going to be, because there's only a certain amount of money set aside for that. So what are the 4 parts of MIPS? You got quality, which replaces the PQRS program, advancing care information, which replaces meaningful use, cost, which replaces the value-based modifier, and a brand new category called improvement activities. And I'm going to briefly go over these, spending most of my time on quality and advancing care information and just a little bit of time on the last 2 there. So the total MIPS score is actually just each one of those 4 categories added together with the weight of that category. And all these categories are not equally weighted, but the total score is 100 points. So I'm not going to get into the point systems used in each one of these categories. Some of it's a little complicated, and we don't have enough time for that today. But I want you to look at that you're looking at this total score of 100 points. And so what is the weighting that we're going to be looking at? On the left part of your screen is the weighting for 2017. It's what we're currently going to be working with this year. And you can see that quality measures are 60% of the total score. Advancing care information, what was known as meaningful use, is 25. Improvement activities, that new activity, 15%. And cost is 0. Cost is 0. So nothing about cost this year. However, you can see in future years on the right, and I think a likely thing that will happen next year is that quality measures, the weighting on the quality measures is going to go down and cost is going to start going up. And the philosophy that I can see what CMS is trying to do is get you used to the system, get used to looking at your measures, doing well on them, learning to submit them. So they're putting a lot of weight on a process type of thing, so that you can start submitting data the way that they'd like to have it. And so I can see this a little bit as they're using it as a learning tool this year, this transition year in 2017. So, so let's take just a brief look at each one of these categories. And I'm going to try to focus them on such a thing that you can understand what's going to do to hopefully improve patient care, and then the activities that you may or may not have to be involved in and doing education along the way. So quality measures, you have to select at least 6. If you were to go to the quality payment program, qpp.cms.gov, it's a wonderful website. And you can see the other specialty sets that in ophthalmology does have one. Optometry does not have a specialty set, and they actually recommend a certain amount of these measures for ophthalmology. A lot of them apply to optometry. There's certainly nothing wrong with just going in and picking those measures. But I'm going to show you a different way that I think you don't have to guess so much with this. But there's 6 of those measures, and then some of them are bonus points for how they're set up. So here's the, I listed the different methods for how you can submit quality measures. And the top one is the claims-based. And so if you are familiar with submitting PQRS measures right now through a claims-based system, just take the route slip or whatever you have, or a tab, and iCare has a tab, the PQRS tab, and you'll just go and click off, you know, the ones you want are on the route slip. You would mark off which quality measures that you wanted to submit on a claim. that is still available. So in fact, AOA actually has a nice webinar on how to participate in MIPS without an electronic health record. And this is going to be one of the ways you can submit the data. So you don't have to have an EHR to do this, but it makes it a lot easier if you have one and you're using it correctly. And then there's these other methods, CSV files, CMS web interface, right out of your EHR. It's called a direct method, or calculating or making these QRDA, usually what they call category 3 reports. And you can submit data that way too. But I do want to point out, like I say at the bottom, that there are 271 different measures from which to choose from altogether. The Quality Payment Program website actually does a nice job that if you pick one of these methods, it will then tell you which one of those 271 measures you can submit that way. So they're trying to make it easy for you. They're trying to give you a different path to submit the data. But if you pick a certain path, you better make sure you're getting the right measures, because you don't want to do all the work and find out, oh, I can't even submit it. I did all that work and now I can't even submit it. Well, the one method is what I'm going to stick with. I want to talk to you about is the registry method. And I think AOA has done a great job of actually designing and making a registry for optometry that's integrated with optometric EHRs that will try to make this job as easy and as seamless as possible for you. And that's why I thought that it was the best way for the Michigan College of Optometry to try to submit its data and participate in MIPS, because it was also by far the easiest method for I as an administrator and also for my faculty to take care of patients and do education, because it's also one of the probably least intrusive types of ways to just participate in an almost seamless manner. And so we're going to talk about that a little bit. What AOA More has done is they just, out of that 271 measures, they selected 9 of them. There's 4 process measures, 2 outcome measures, and 3 high priority measures. And remember, you only needed 6, so these are 9 measures. And actually, you wouldn't even have to be limited to 9, but AOA More has only picked 9. But you could pick 10 or 15 or 20 of them if you wanted to, depending on your method that you want to submit it. But I would recommend to do what AOA has already suggested. Why not focus on some really good ones that are pertinent to you and your practice? Now, you may agree or disagree with the measures that AOA has actually picked, but at least they're ones you can concentrate on to work with. So let's talk a little bit about the measures themselves, just briefly. And here's the 4 process measures that diabetics have an eye exam. Diabetic retinopathy is severity in the presence or absence of macular edema, primary open-angle glaucoma, that an optic nerve was evaluated, and tobacco use, where it was or counseling about screening and cessation. And my question to you, do these kind of look familiar? Well, yeah, if you've been doing meaningful use for the last several years, these are quality measures that have already been used in the PQRS system. So they're not all that different. They're not a whole lot different than what you may have been doing. You may have been used to this for the last several years. And so I've been doing that. I've been recording that. I've got my software updated. I've been putting the data in the right place. And so, hey, this is great, because it looks like I don't have to do a whole lot of anything. And that's what's really, I think, nice about this system, if you've been keeping up to date with everything. So just an example, here's a screenshot of the posterior tab in ConfoLink's EyeCare Advantage, and there's specific data fields that are italicized and bolded, and just like under the old meaningful use kind of annotation in the record, they would do that so that when a clinician looked at that they would say, that is data used for meaningful use, but it's also useful for me to manage the patient, to document their case and manage them. And so there's a dual purpose for me, making sure I get those filled out right. And so here's the one measure about diabetic retinopathy, and the 2 pieces of data you have to put in the record in the right place. And I will say, though, data in those fields is what's known as structured data. In other words, that's why you can't free type in those areas. You have to use a drop-down list and pick the answer, because this is data that's going to be used and analyzed for the quality system. And it can't be compared to other people or other providers unless you've got it in a standardized kind of format. So you got to put it in the right place and you got to use it the right way. So one thing that I did for my faculty back in December, I went through all these measures that AOA Moore had, and I wrote down kind of a cookbook for them that I sent to them. These are the kind of things you have to do, and this actually came right out of CompuLink's help menu. And I said, this is what you need to do, and this is how you have to record it. So at least it's in the software. And a lot of it is exactly normally what you've done. Some of it's a little bit different. You know, if you're sending communications in and out, using the portal, secure messaging, those are kind of new, you know, in the last couple of years. You may or may not be used to that kind of stuff, but certainly documenting things in the record appropriately is exactly where you have to go. Here's the 2 outcome measures, just so you know what they are: controlling high blood pressure and diabetes, the control of diabetics, and then the high priority measures, documentation, current med, closing referral loop, and communicating with the physician about diabetic retinopathy. So those are the measures, although every software package, even though AOA Moore says this is what we're going to try to measure, every software package out there has a different way of where you need to put that in there. So you've got to get with your software vendor or have some document or something that'll tell you exactly how to put that in there. Otherwise, you're not going to get credit for it, because the software is going to try to keep track of this. And when it does a report, you may think you've done everything correct, and you run a dashboard report and you don't see anything. And that's because you didn't put it in there. Most of the time, it's just because you didn't put it in there. So you got to practice that maybe a little bit. But here's the beauty of the thing, is that when you get the latest version of your software and get that installed, you and your students, all you have to do is record your data in the correct data fields, which you're going to do anyway. So it's really not a whole lot of extra work on your part, as you just document things in the right places for most of these measures. Then the data will be extracted from the EHR about once a week automatically. It's sent to AOA Moore automatically. AOA Moore sends it to CMS automatically. You as a teaching clinician really have very little or anything you have to worry about doing. And if you do get your data submitted in as an individual, you can individually go in and look at your data compared to the national average right on AOA Moore's website. And so you'll be able to see that without having to go to CMS's QRUR report system and looking it all up. AOA will try to make it easy for you, at least for the measures they're going to try to collect. So that's it with the quality measures. Now we'll go on to advancing care information, which is 25% weighted at total 100 points. And there's 3 basic categories for advancing care information. There's a base score, performance score, and a bonus score. And the thing about the base score, you know, I talked earlier about MITS being kind of a graded thing from 0 to 100 points. But with the advancing care information on the base score, you don't have a lot of choice. You're not going to get your 50 points there unless you do it. You've got to do it. If you don't get that base score, you're not going to get any performance score, and you're not going to get any bonus scores. So the base score has to be done no matter what. And so we're going to talk a little bit about what that is. There's a couple of different measure sets, though, and it depends on if you want to pick to go with a regular or transition period method. And you're kind of tied into the type of software that you've got, because if you have a 2014 certified EHR, you're stuck with the transition objectives and measures for this advancing care information. You don't have any choice. And as far as I know, even CompuLink's latest version is still the 2014 certified EHR. I don't believe they come out with a 2015 certified EHR yet, but I wouldn't be surprised if they will sometime. But if you have a 2015, you have a choice. You can go with a transition or the full. I don't want to confuse you with any of that. I just want you to know there's a difference. But more than likely, you're going to be looking at these measures in the right box more than you are the left one. So here's the things in the base measure detail, and we're just going to use the transition criteria and tell you that you, just like Lisa talked about with Hipaa and all that, this is one of the reasons why you're going to do a risk analysis, not only required under Hipaa, it's required for advancing care information and MIPS. So you're going to perform your annual risk analysis, and you just say yes or no. You have to e-prescribe for at least one patient. You have the health information exchange, you electronically transmitted summary of care to one patient. Provide patient access to their record, like a continuing care document, to one patient. So when you look at that, I said that's the base level. Well, gee, yeah, I think I do all of that without any problem over a 90-day or an entire year. Hopefully you won't have too much trouble meeting the base measures. So it's just an example of what one of these look like. Some of them are required for the base score, but like provide patient access also is used in the performance score weight also. So it's required for base, but you can earn some bonus points too for actually doing it more than just that one time. And that's exactly what you want to try to do. And then those performance measures are then graded, and these are the different percentages on some of the different measures. And so they'll all add up to something, and a couple of these are worth more than the others. But on the table on the right, the thing I want to point out is that in order to earn the full 10%, say, of patient-specific education, that your performance rate has to be, if you're going to get the full 10%, you've got to be doing that 91 to 100% of the time. Okay, so if you're only going to go halfway, you're only going to get half of it. So do it 41 to 50% of the time, then you'll get 5%. And it's kind of funny how they use these percentages in these calculations, but it is what it is. So don't think that patient-specific education says up to 10% for the performance score that you'll go back to thinking about the old meaningful use, thinking, oh, I only have to do that on 10% of my patients. And that's not correct under this system. Under this system, in order to get that full 10%, you've got to be doing it almost 91 to 100% of the time. So that's the big difference. You're going to get rewarded for the extra work, but you got to do it quite often to get the full performance score. And here's just another example of secure messaging, that it's just not used as a required for the base score, but it is a performance score. And the more you use secure messaging, just the more you'll be rewarded. And here's the bonus measures, which are actually, I think for most optometrists and even most optometric institutions, are going to be a little bit tougher to comply with because it involves some things we don't normally do: syndromic surveillance data, electronic case reporting, public health registry reporting. Optometry is hardly ever involved in any of those things. We do have a clinical data registry, AOA More, so we do get 5% for that. So in the bonus measures, just by participating with AOA More, you're going to be able to pick up a little bit extra points there. So let's go on to our third of the four categories, the clinical practice improvement activities. It's only worth 15% of the score this next year. And really, it's just coming down to picking some activities. And there's a list of 92 different activities that you can pick. And you have to do them for a minimum of 90 days. You need 40 points total for 2017. And they're in two different weights, medium or high. And so you'll look and see if you can find the right number to get you up to 40, and then do those activities. And you have to complete the activities to get the whole 40 points over that 90-day period. So there's no partial, this is another one of those things where there's no kind of partial credit for it. You just have to do them. And so, and I wanted to point out that one of those clinical practice improvement activities is the use of a qualified clinical data registry, which AOA More is. So there's some points that you can get for that under the clinical practice improvement activities. So AOA More is actually helping you in more places than you think. And here's our last one, the cost, the resource use, which is by far the easiest for anybody to do because you don't do anything. CMS will finally send you a letter, and anybody who's been submitting data and using the value-based modifier over the years has been getting these reports back. And actually some of this data is available through CMS. You can look up surgical outcomes, say for physicians working in hospitals and things like that, and see how their cost or resource use is. And so CMS will calculate this, and then they'll send you something to let you know kind of how you did with that. And that's about all there is for it. So nothing this year, but remember next year they're going to start looking at that. The one thing I did want to point out, just like we heard before, that CMS is a little bit like Big Brother in that they're watching everything you do. So if you're sending these measures in, these quality measures, and participating in MIPS and things like that, that these things will end up on CMS's Physician Compare website, which is available to the public. And the public can go then and look and see if their physicians are doing quality work or not. So this is the one thing I think most practitioners in the field are just a little surprised about, because they always thought that their data was going to be between they and CMS, and but they don't realize that this is going to happen too. And so patients are going to be selective about where they go and everything else. So that's the other reason why students, I think, need to learn about these things, because the growth of their practice is dependent on these. And just some references for you there. But that's all I had there, and it'll be my pleasure now to turn the presentation over to Dr. Pence.
Thank you, Dave. As you can see, we've got the contact information for our presenters here from MCO. If we can keep Dr. Durkee's mic live and also turn on Lisa, and also turn on Dr. Damari as well. We have a couple questions. I'm going to start with you, Dr. Durkee. There was a question as to how do you present this information to your faculty? Do you have meetings where you have gone over MIPS and Macra, or you do it through emails, or how exactly do you keep your faculty updated?
Well, what we have done in the past, and we do plan on doing it here again actually pretty soon, is we're going to have presentations. And I do have some outside consultants that I can use too to come in and make presentations. And so all I've done this year is I have looked at individual dashboards, and I've been with some faculty. I kind of tell them where they are at and give them some feedback individually. And we will have some faculty development, and then that one document that I told you about. You know, faculty are just so busy with so many activities. You know, this is just one other thing on top of that, and just a little bit of things that I can do along the way that can remind them or help them out is about the best that I think that I can do, because I know their time is valuable, and so I want to give them information as quickly and as easily as possible over probably quite a bit of time with feedback. So
that takes us to maybe a second question, which I wrote down here. You mentioned going to get rewarded for the extra work. And in fact, clinical faculty are probably not going to get rewarded. The institution might get rewarded. How have you taken into account the extra effort and work, even for meaningful use in the last few years? In terms of teaching workloads, workflows, have you made any adjustments to that, or has this just been sort of an add-on to all the clinical faculty?
It's been an add-on. The faculty have not shared financially in any of this, but they are very aware. I share with them the financial parts of the operation quite regularly, and so they can see where the rewards of their efforts by being able to still continue the high quality operations and be able to acquire equipment and keep the systems working into place by participating in these systems. And so on that part, there's not a financial reward, but they can still see that they can still help and participate in the quality of the clinical instruction by making sure that they can help keep the clinic financially viable. And I think that's the one thing about our faculty that I really enjoy and appreciate, is that they are very interested in that. I don't bog them down on all the details of all those things, but they do realize it has the bottom line, and it does affect their clinical education and patient care. So that's about the best I can tell you about that.
Well, Dave, I think that's an excellent answer. Just as a comment, I can say at IU we do have faculty who are eligible under MIPS, so we will be reporting for individual faculty that are eligible and not doing the group reporting. And it turns out if you have faculty that are eligible, that's also where the greatest amount of financial reward can come from for reporting for those.
Yes.
Is Dr. Damari on the line?
I am.
There have been several questions from our audience just asking about a little bit about what did the mitigation of the Hipaa breach. Can you give us a ballpark, or are you comfortable sharing a ballpark figure of what that might have cost the university?
Yeah, sure. And that's pretty much all I can do right now because I didn't bring my whole budget sheets with me. Sorry about that, Dr. Pence. But I can tell you that it's costing us about a 0.5 staff FTE every year right now. And that's the college. The university did hire a law firm, and I'm not sure what their costs on that are, but my estimate would be that it costs the university altogether, including the outside consultants and staff time, probably somewhere upwards of $50,000 or $60,000. And it costs like I said, our college, out of our budget, it costs us about 0.5 staff FTE every year. And there were several other things we had to purchase to help mitigate our risk. But overall, I would say our cost was just into the low 5 figures for the college. So that sounds like a lot of money, but certainly it's a lot less than the fines would have been by far. And so I think, it's just a cost of doing business that's a lot less. I'm kind of shocked at Children's Hospital of Dallas, but for them, the cost of doing business for just paying OCR the fine may have been less than all the mitigating costs would have been, and they may have made a business decision there. We don't have those kind of resources at our university, so we chose to mitigate, to document, and again, I want to thank Dr. Durkee and especially Lisa Roach, because they spent a lot of weekends and a lot of sweat, and probably need a lot more eye care after looking at all those spreadsheets and mitigate our situation.
Yeah, I think that cost actually sounds not at all high, very reasonable. I think a good number of folks are aware that there was a university, and it's not IU, but they have shared it with other universities that spent over $1 million to get a good system in place and to be highly compliant. So compliance is not an inexpensive cost to all the universities. So at this time, I'd like to really thank all of our presenters. There was also one question about would there be CE credits for this. We have not arranged for any CE credits. We have not gotten COPE approval for this. It is possible that certain universities could apply to their individual state boards, and there might be the potential that you could get credit if you want to do that individually for individual state boards. At this time, I would like to thank everyone for their participation, encourage you once again that we would certainly like to have your participation in the surveys, so please be sure to fill out the survey at the end of this presentation. And at this point, I'm happy to turn the program back over to Dean Damari.
All right. Thank you, Dr. Pence. And let's see. Oh, yeah, now I'm starting to show up here. So let's advance here. Complete our survey, if you would. There's the survey link. You can get to it later. You can get all these materials later. I want to thank, first of all our speakers for their time and the expertise they've shared here today. I want to thank both the Clinical Affairs Committee members and the forum co-chairs and planning group members. An additional thanks to Dr. Pence, who has been involved in this forum since its inception in 2011, and I can tell you provides great leadership in what we do for this. And of course, Carol and LaShawn at ASCO, can't do any of this without you. So anyway, this has been made through a generous contribution of the ASCO Clinical Directors and Administrators SIG. And so if you've been following this webinar as a group, please have each attendee sign an attendance sheet, and the institutional liaison should send the copies of the attendance sheets to Carol Brubaker. And that's it. Thank you, everyone, and have a great weekend.